Good morning. I'm Alan Weil, Editor-in-Chief of Health Affairs. We're very pleased to have you here today for our briefing related to the release of the March issue, Patients as Consumers. Very proud of this issue, and I know you're going to have an interesting morning ahead of you hearing about the content included in the issue. Words matter, and one of the key areas of focus as we were putting this issue together is how to handle the word consumer and the term consumer. We know there are strong feelings about use of that term. And I just want to give you a sense of where we landed and why we landed here, because if you're here, you've probably thought about this question as well. What we've done in this issue is bring together two streams of thought, and it's part of what I think makes the issue rich and will make it of lasting value. Certainly, the financial demands placed on patients and families at the point of care or at the time of choosing health insurance, those financial expectations have increased. This is well known. We are asking people, the healthcare system is asking people to make economic decisions and choices. And if you go to conferences in the healthcare sector, you hear lots of panels on consumerism. This is a reality. At the same time, there are years of efforts to bring patients into the decision-making process around their care, particularly related to quality. Again, quality of the clinician, decision-making around specific procedures and choices people make, the quality of the health plans, the various federal websites that rate nursing homes and hospitals on quality. And it turns out that that effort has also been complex, that we don't have an easy way to communicate quality. But in the end, what the healthcare sector does in many instances is give people choices. Sometimes they don't have choices, but when it does give them choices, there may be information about the quality, there may be information about the cost or the price, and it's up to the patient or the patient's family to make a decision. It sounds a lot like what we ask consumers to do in other sectors. So we have papers in the issue that challenge the concept, and I'm glad that we do. But I will say that whether people like it or not, the healthcare sector is expecting patients to act as we expect consumers to act in other sectors, and that's the frame of the issue. And that's why using the word from our perspective was important, even though it's also controversial. It raises a second issue, which I know is on the minds of people who attend our events all the time, which is, where are the patients? And the answer is, this is the release issue of a scholarly body of work. Because of the close involvement of PCORI and the leadership of PCORI that I'll get to in a moment, we are seeing, in many instances, great increases in patients' involvement in research. But at the end of the day, we are a peer-reviewed journal, and today's event is for the authors to present their findings. This information then goes out into the world, and many more policy discussions we hope will arise from it. But we structure all of our release events around the authors of our papers, and that's who you'll be hearing from today. It takes a lot to put an issue like this together. I want to thank Dominic Frosch of the Palo Alto Medical Foundation. He served as our theme advisor. We also, it takes financial support, and the lead support for this came from the Patient-Centered Outcomes Research Institute, PCORI. We also had support from the New York State Health Foundation, and that's critical to us being able to put the issue together and hold this event. There's no easy way to organize the content. We cover a lot of ground in this issue, but just to give you a preview for the day, we're going to have a series of papers that talk about how patients are engaged in their care, the increase of information that patients and clinicians are expected to use and integrate into their thinking. We'll then move into the research enterprise, which is increasingly an area where patients want to be involved, and researchers are finding ways and also dealing with the challenges associated with involving patients in the research enterprise. After a break, we'll talk about some of the more traditional economic side of consumerism, shopping for care, asking patients to balance cost and quality. Move into a number of papers that look at health plan design, which is being used by a number of insurers and employers to try to guide people in their choices that they make as patients. And close with a number of papers that look at health plan choice, another area where people act as consumers, often before they are clear what their role will be as patients, and so it's a somewhat more traditional consumer view. So we hope you'll enjoy the presentations today, engage with us through the conversation, and as we get started, I want to turn to Kristin Carman, the Director of Public and Patient Engagement at PCORI. As I said, PCORI is was the lead sponsor for this issue and helped bring us together. Kristin is the Director of Public and Patient Engagement. She leads efforts to see that patients and other healthcare stakeholders are fully involved in and guide all aspects of PCORI's work. Please join me in welcoming Kristin Carman.
Thank you, Helen. I really appreciate that introduction. And I feel like I've been saying this for a month and a half now. Excuse my voice. I've got whatever that illness is everybody in DC has, so doing better, but I still can't quite get my voice right. Good morning to you all. I'm really delighted and thrilled to be here today, and I'm so glad to see so many of you interested in this special issue on patients as consumers. I also want to note that our chair of our Patient Engagement Advisory Panel, Dave White, is here today. I just want to point him out. Dave and the PEEP have been really instrumental to both the vision and the approach that PCORI takes to engagement, and involvement of folks like him have been critical to where we are. I also want to note that we have some of our ambassadors in attendance who are also very important and do very important things to us for our work and sharing what PCORI has done. Last but not least, I want to thank our colleagues from the New York State Health Foundation, who are really strong and terrific partners in our shared work to ensure that patients, caregivers, and families are really at the center of health and health care. So this issue really highlights both ongoing challenges and changes underway today. So today, the concept of consumerism, I think, is generally understood to mean that people are actively engaged in making decisions about their health and health care. They have access to useful information and appropriate technology so they can make better informed decisions. There is now more information about what is effective care, certainly measures to assess that care, and, as Alan mentioned, burgeoning attempts to share the price of care. So that should mean, right, that patients are increasingly empowered to make healthcare decisions and be healthcare decision makers, right? Maybe not so much all the time, because more is not the same as better, as we all know. Nor is it necessarily what is most useful or usable to help individuals make decisions that reflect or help them achieve the outcomes that matter to them. Consumerism in healthcare remains elusive because fundamentally healthcare does not function like other markets, right? It's incredibly opaque and Byzantine. Information is too often asymmetric, both in content and timing. And even, for example, when physicians and patients have information at the same time, it may not be equally relevant and useful at that same time. So the good news is we see some genuine and meaningful change, even as we still see challenges to overcome. PCORI itself was authorized by Congress in 2010. We were to fund research to help patients and those who care for them make better informed decisions about health and health care. So from our vantage point, the road to a patient-centered supportive health system begins with much greater involvement of patients and consumers in health research, which is where the information to support decisions is really generated and started. So to date, at PCORI, we funded $2.4 billion in research and related initiatives. Now, most are studies that compare two or more healthcare options, looking at outcomes that matter and are important to patients to determine what works best for whom. So for consumerism to be successful, we think patients have to be active participants not only in their care and using evidence about what works, but also in an effort to generate that evidence and to disseminate it. So in other words, unless patients and other healthcare decision makers participate at all stages, we really won't end up with a healthcare system that we all want, which is patient-centered, efficient, and effective. And again, this issue highlights progress towards this vision and the challenges ahead. So you're going to get to hear from a variety of speakers today addressing a number of important topics throughout the morning that Alan mentioned, in addition to other papers. Among the participants in this briefing are a number of individuals who have worked closely with PCORI, and we're great to see them here. Kate Bundorf, Jonathan Dillman, Ming Tai-Seale, Consola Wilkins, and my colleague Laura Forsyth, who's going to discuss some work that we've created within PCORI. It's also important for those of us who primarily identify as researchers, clinicians, and health executives to really hear from patients and other healthcare decision makers. So it's terrific that we're also going to hear from Hala Dara today, who is the mother of a chronically ill child and someone who I know personally and I've seen grow into an extraordinary advocate and supporter and thought leader really on how to support engagement in this world. I'd also like to note that while this issue is a terrific resource, there's a lot we all need to continue to focus on to advance the new healthcare consumerism so that we're sure that it benefits patients, families, and the systems to achieve the goals we want. We describe several of these in a blog that's going up on Health Affairs today. I strongly encourage you to take a peek. But just as an example of a key question to be addressed that's really actionable that we still have to work on is, what are the most important opportunities for true shared decision making? Right? Is it preference-sensitive decisions where patients can be supported to make the best decision based on evidence regarding the options available to them, based on risks and benefits? And if so, how do we promote shared decision-making in these circumstances? And how do we move from a situation where it's applied in an ad hoc way to understanding when it should occur and to really have a shared consensus around this between patients and other stakeholders so that it is systematically applied? We are indeed, I think, at a key inflection point. At PCORI, we've learned that by systematically and consistently supporting the engagement of patients and the public as collaborators and partners in research, people can and do play critical and invaluable roles at key junctures as patients, as consumers sometimes because decisions force them into that role, as caregivers, and as citizens. We're sometimes thinking about just not what matters to them, but what matters to their community and what matters to the world. What is most critical is to ensure the meaningful participation of the public at all of these stages in the generation of the evidence to ensure its usefulness and its uptake, and to realize that engagement is essential to moving forward both research and practice. Thank you.
Thank you. So I'm going to ask our first panelist to come up. Okay, as they're making their way up, our first segment, as I mentioned, is about engaging in care. We'll hear from Karandeep Singh, Assistant Professor of Learning Health Sciences, Internal Medicine, and Information at the University of Michigan. Lise Rybowski, President of the Severin Group. Ming Tai-Seale, Professor in the Department of Family Medicine and Public Health at the University of California, San Diego School of Medicine. Michael Guzmano, Associate Professor in the School of Public Health at Rutgers University and a Research Scholar at the Hastings Center. And Hala Dara, a nationally recognized speaker and patient family engagement consultant and advocate who wrote the Narrative Matters piece in this month's issue. So let me turn it over first to Karandeep.
And I don't have any slides. Oh, you don't? Yeah. So that should make it easier. So today you'll hear about some of the tensions surrounding the idea of treating patients as consumers. While there are many reasons why this idea should give us pause, I think that some of this tension stems from the historic imbalance in power between patients and their physicians. This imbalance in power is not only due to differences in medical knowledge, but also to differences in ownership of things like patient data. It wasn't that long ago that if you wanted to get access to your own patient data, that you would need to drive to the medical records department of your local hospital, wait in line, sign authorization paperwork, wait for the printer to do its job, and walk out with a binder full of documents. That power imbalance has slowly started to shift. With the passing of the HITECH Act in 2009, healthcare providers were incentivized to adopt certified electronic health record systems that were designed to meaningfully improve care. A consumer engagement work group at the time advocated for the idea of making patient records available to patients at the click of a button. This central idea came to be known as the Blue Button Initiative. When it came time to define what are the core functions of a certified electronic health record, giving patients ready access to their own health data was included as a core function. So giving patients easy access to their own data marked a turning point in the power imbalance between patients and providers. Physicians have also historically served as the gatekeepers of reliable medical information. In the early days of internet search, there was a name given to this phenomenon of going online, searching for symptoms, and coming across results that reflected the most serious symptoms and serious diagnoses as opposed to the most common ones. And this came to be known as the Dr. Google phenomenon. And the harm or illness caused by this phenomenon was termed cyberchondria, or fear of information. Much has changed since these early days. Since mid-2016, searching Google for medical information results in the display of reputable medical information from health centers like Mayo Clinic alongside the usual search results. And there are also a number of websites that have cropped up aimed at providing healthcare quality and cost information directly to patients. So with patients having more access to reliable medical information and quality information, some of that power imbalance has shifted further in the favor of patients. Beyond data and knowledge, helping patients with medical decision-making, and providing counseling are among the key ways in which physicians continue to help patients. And even here, many decisions need to be individualized. So you have to take into account risks, benefits, and also patient preferences. Increasingly, patients have access to apps and tools that seek to help them in their medical decision-making and provide counseling on things like diet and exercise. The imbalance has shifted so far in some areas that there's often a reverse imbalance that exists today, particularly when it comes to patient data. Through wearable devices that track key markers of health and wellness, patients often have access to data that physicians do not. While some of these data may be clinically actionable, healthcare systems don't yet know how to deal with and respond to this potentially massive influx of data. So as a result, they've been slow to accept incoming patient-generated data and act on it. With all these data, information, and tools available to patients, it can be easy to assume that patients will be able to differentiate what is high quality from what is low quality. And if I were to ask you how many apps and tools are out there currently today, well, I could tell you how many health apps are on the marketplace exactly right now, but that estimate would be out of date by the time I finish this sentence. The truth is that there are so many resources that we cannot ask patients to do this on their own. In our paper, we provide recommendations for how we as healthcare professionals can help patients find the right tools and how we can be good stewards of patient-generated data. As a medical community, when we release guidelines asking patients to track a specific health measure, we should also point patients to apps or tools that can help them follow through on these recommendations. When misleading apps pervade the marketplace, we need to ask the Federal Trade Commission, which has the authority to take these apps off the marketplace, to intervene and remove the dubious apps from the marketplace so patients have less to choose from. And when patients want to send their own data to the health system, we need to figure out how to help patients triage and respond to this data rather than ignoring it. In the digital age, it's no doubt that the role of patients has changed. It is inevitable that the role of physicians will need to change as well to adapt to the needs of the digital age. This change won't be easy. Thank you.
You're apparently getting a preview. Good morning. I just want to start by saying that I'm here representing a team of researchers that are based at the Yale School of Public Health and the RAND Corporation. We've done this research with funding from the Agency for Healthcare Research and Quality's CAPS program. So as many of you know, since the 1990s, there have been many hundreds of different efforts by public, private, and nonprofit organizations to put out information in the form of websites and reports to inform the public about the quality of healthcare providers, all of which is with the goal of helping consumers make more informed decisions. And various surveys that have been done since that time have concluded that nobody's paying attention, that very few people know about these reports, and that exposure isn't really changing much over time. But the environment for public reporting has changed in the last 5 to 10 years with respect to both the content of information that's available as well as the sources of that information. And so given those changes in the environment, our team decided that what we wanted to do was take a fresh look at the issue by asking a question that's been asked several times before, which is, are people saying the information that compares the quality of healthcare plans and providers, and asking for the first time, what kinds of information did they see? So, sorry about that. This is slow, isn't it? Okay. So the first major change in the environment is the upsurge in patient-reported information, specifically patients' comments about care. So this is a new spin on a pretty traditional source of information. When making decisions about healthcare in general, providers in particular, we've all been asking our friends and family for advice for a very long time. What has changed is our ability to consult with a large number of people, easily, quickly, and anonymously, thanks to the rapid rise of user-generated content on the internet. So we're now able to share our experiences and to obtain information about other people's experiences with local providers from a large number of people without having to leave our home or our telephone. And so while it may seem like we've been reading these kinds of reviews for a very long time, it actually hasn't been that long. This type of information is a mixed blessing. On the one hand, patient narratives have the appeal of stories, and so they may make quality reports with quantitative information seem less daunting. But many of the sites with patient comments don't have any other information on them. And there are reasonable questions about the validity and the usefulness of the kinds of comments that are out there right now. The second change involves new information sources. I'll just keep going, that are familiar to and trusted, there we go, and trusted by most American. And these include sites that we all use every day, right? Like Yelp and Angie's List. And we use it for many purposes. So adding healthcare information makes it easy to stumble across. The websites, it also includes the websites of over 100 healthcare systems, which are typically pretty well known and trusted in communities. So these news sources make it easy for people to find healthcare quality information when they're looking for it, and also, as I mentioned, more likely for them to stumble across it when they're looking for something else. So in just a little more than a decade, there's been a huge growth in the amount of publicly available and largely free information on clinician quality, particularly patient experience. But we know from 2 decades of public reporting on healthcare quality that the availability of information doesn't necessarily translate into the awareness and use of that information. So that raised the question, is anyone paying attention? And our study was designed to answer that question. So as part of an experiment, a larger experiment that was testing different strategies for reporting comments about doctors alongside other comparative quality information, we surveyed the study participants who were representative of the population of American adults. In 2010 and 2014 and 15, we asked the same question that the Kaiser Family Foundation has been asking for years. Have you seen any information comparing quality among different health plans, hospitals, or doctors in the past 12 months? And our findings, as you can see on this slide, suggest that exposure to information about doctors, which have been fairly flat for about a decade, grew steadily from 2010 to 2015 from about 16% to 26%. Awareness of hospital information, on the other hand, remained pretty level. Our survey also asked respondents what types of information they saw. So exposure to any type of information on physician quality increased over time, pretty much almost doubling from 15% to 2010 to 30% in 2015. But as you can see from this graph, our results indicate significant growth in patient-reported information, so both patient experience measures and patient comments. Moreover, when we last fielded the survey in 2015, nearly 8% of all respondents indicated that the only type of information they saw was patient comments. So when you only look at the people, when you only look at the people who say they saw any information, that's about a quarter of the people who see information on physician quality. Two other findings I wanted to share is that 2014, we saw an educational gradient we didn't see in 2010. So basically now, the more educated you are, the more likely it is that you're seeing this information. We didn't see this in the past. Another increase that we saw that caught our attention was a difference across racial and ethnic groups. 2010, there wasn't that much of a difference. By 2015, the disparities by race and ethnicity were consistent and larger. Minority populations are consistently more informed than whites, with greater exposure to both quantitative information and patient comments. And most of these patterns held up even when we adjusted to various factors, like active seeking for the information. So in summary, our study found that Americans are substantially more aware of physician quality information than we would have predicted based on previous data. They're seeing several types of quality information, including patient comments, and for many people, patient comments are the only thing that they're seeing. So we'd like to see some additional research, ideally, that would dig into some of these findings. So, for example, what do people think how do they interpret the information when they only see one type of information? Do they even realize there's anything else out there? Also, what's driving these racial and ethnic disparities in exposure to healthcare information? As for the policy implications, our main concern has to do with the growing dominance of patient comments. Are these comments information that people can actually use to make good decisions for themselves and their families? And is this information that providers can use? We'd like to see some standards for gathering patient comments so that the information is representative of the patient population and gives a complete picture of the care people can anticipate. A second issue is how narratives are integrated into quality reports. How can we do that in a way that gives us a complete picture both of the comments, the narratives, and the quantitative information? And finally, there's some potential for taking advantage of these higher levels of awareness among minority populations. And finally, my last comment is that we would love to see another survey. The last one was 2015, so we'd love to see another survey to see what has happened since that time. Thank you.
Good morning. I am here to present to you joint work with colleagues who are esteemed leaders in health IT from 4 organizations that are featured in this paper on technology-enabled consumer engagement practices. And I want to thank PCORI for partially funding the work that we're presenting here. So patients' journey in healthcare vary a great deal depending on how the supply side of health services or health information may integrate technology in this day and age into their care process. So patients spend most of their time outside of hospitals, in communities, in their homes, and in ambulatory care settings, and then some patients do end up in the inpatient setting. So this study will showcase 4 organizations in their approaches in patient engagement across the care continuum. Okay, I hope the Okay, it'll wake up. I'll start talking about, the first organization is Ochsner Health, which is where is the computer? Which is a integrated delivery organization in Louisiana. Whew. And okay, well, we can forget about the animation. You'll just see them all together. So in 2015, Ochsner decided, because Louisiana ranked number 4 in poor management of hypertension disease, so they decided to start a pilot test of a digital hypertension management program in which they provided to patients whose blood pressure is not well controlled, and patients are given access to not only the devices, but a O-bar, which is modeled after the Genius Bar in Apple Store. So the staff there would help patients set up the gadgets and show them how to use them, and then the readings of blood pressure gets transmitted automatically into the electronic health records, fed to the clinicians and the multidisciplinary care team, which included not only physicians, but also pharmacists and health coaches. So after 6 months of this pilot project, compared to propensity score matched patients, the patients in the pilot study had a much better chance of having blood pressure under control, at close to about 80% compared to 20-some% of patients in the control group. And medication adherence rates were also much higher, and patients reported better satisfaction with care. So that's a story from Ochsner. The second organization is Sutter Health, which is a large integrated delivery system in Northern California, serving over 3 million patients. So they are one of the early adopters, developers actually, of Patient Portal. Currently, they have about 80% of their patients who have an activated account in their MyChart program, with over 30% of them made at least one appointment using the Patient Portal. And they also have leveraged the Patient Portal to send out clinical decision support alerts to both patients and primary care physicians, leading to speedier completion of diabetes monitoring tests and also better diabetes management outcomes. The third organization is Stanford Medical, which is an academic medical center in the Bay Area. They also enjoy a very high patient adoption rate of their patient health portal, and they are leveraging the patient health portal to survey patients in oncology department after recognizing that perhaps a large percentage of their oncology patients may have unaddressed distress. So before patients visit, patients would answer surveys through the Patient Portal. And as a result of that survey, they found that 40% of the patients who answered those surveys, which is about 13,000, had unaddressed distress ranging from transportation to depression and some to suicidal ideations. So that resulted in over 6,000 referrals to psychotherapy, to nutrition, and to other wraparound services, leading to great positive feedback from patients and providers. And the last organization is the University of California, San Diego Health. They have incorporated the Patient Portal in the inpatient side as well, in addition to the more usual ambulatory care Patient Portal. And in this picture you see is a patient in the bone marrow transplant unit using a tablet which is hardwired into the new large Jacobs Medical Center, that patients could access an app that will help them control the room environment, like temperature, like lights, like sound, watch television without needing to leave their bed. So in the same tablet, there is a portal to the inpatient patient portal. What we found after looking at data over a 3-month period, 2/3 of the patients use the room control feature on the tablet, and 1/3 of those people also use the patient portal, which enable them to look at their upcoming procedures, their lab test results, communicate with their providers, and looking at the profiles of their care team, hopefully, to facilitate their engagement in their care process. The last picture you see here is a pilot study. Well, it's a study that's funded by PCORI that Sutter Health and UC San Diego are doing to engage patients before the ambulatory care visit by entering their priorities into the patient portal to help them and the physicians to jointly set agenda for their visit. So these changes didn't just happen like by flipping on the switch. A lot of change management strategy had to be implemented, workforce implications had to be addressed, and payment issues are also very important. With healthcare organizations or the supply side of care organizations getting more collaboration with consumer health technology companies, I think we're going to see even more patient engagement through these technology. Thank you.
Good morning. I'm now officially afraid of this clicker, given the experience of everyone else in this room. It's a pleasure to be here. I want to thank Dr. Weil and the staff at Health Affairs for inviting me. I'm presenting an essay that I wrote with 2 colleagues from the Hastings Center, Karen Maschke and Millie Solomon. We're here, I think, officially to be a pain in the neck. And as Dr. Weil said, raise questions about language, because we do think language matters a great deal. Much of what went into this essay flows both from my work doing cross-national analysis, looking at small area variation in the use of medical care in different countries around the world, including the US. And some of it comes from more recent work I've done with Karen Maschke, looking at how we use different criteria for evaluating medical technologies. So I'll begin by saying we actually fully embrace the mission of PCORI and the idea that care should be more patient-centered and that consumers should be more empowered in terms of making medical decisions and confronting a sort of long history of physician dominance. Let's see if it works. Hey, it's very exciting. Right, and so this concept has been around for a long time. Actually, if you go back to the late 19th century, you can see sort of precursors to what became known as the consumer-centric or patient-centered movement, if you look at some of the push in mental health services and certainly in women's health. And it really took off in the 1960s. Ralph Nader's group had a big push for empowering consumers and providing them with better information, allowing them to make better decisions. This got another boost in the mid-1980s. Harvey Picker, who many of you may know, was a philanthropist whose wife had a bad experience at the end of her life, and he wanted to make sure that patients would be empowered to make decisions, that they wouldn't be treated like imbeciles by physicians when they were receiving care. In collaboration with the Commonwealth Fund, they started the Picker Institute, which did a great deal of important work promoting patient-centered care. And then by the time you get to the beginning of this century, the Institute of Medicine put out a series of reports calling for greater patient-centeredness in healthcare. And there's a lot of evidence. Some of it shows up in this new issue by Health Affairs, suggesting that when care is more patient-centered, it actually improves outcomes. If you go back, however, to an earlier version of Health Affairs, Don Berwick, former director of CMS, argued that he didn't really care about that, or he did care certainly about improved patient outcomes, but he thought that patient-centeredness was a value in and of itself, that regardless of the impact on outcomes, we should be placing greater value on patients and their preferences and their values. This also flows from the work that happened in the 1970s, again, looking at small area variation, something I referenced before. When John Wenberg and colleagues at Dartmouth were looking at this sort of small area variation in care, it became very clear that a lot of this was provider-driven, that patients didn't have an adequate say in what was going on in their care. Our concern is about the use of language and, in many ways, the co-optation and appropriation of the language of consumers. Most of the early history of this was about empowering consumers, about providing them with tools that would make better decisions. And indeed, a number of the presentations that you've already heard this morning have talked about that. But in recent years, this has come to sort of really represent an effort to promote market-based solutions to the healthcare system. In his introductory remarks, Dr. Weil said that whether we like it or not, patients are going to be asked to act like consumers in other sectors. And that may be the reality, but we don't have to like it. And in our essay, we actually argue against it. We think it's a bad idea, and for many well-known reasons. Right? Healthcare isn't like other sectors. It isn't like purchasing T-shirts, and as I'll get to at the end of my talk, it also isn't like ordering hamburgers. So we're concerned about this sort of co-optation, and this, again, draws from some of the work I've done in comparative health systems. If I look at how other countries have helped to reduce prices, to constrain healthcare costs, to improve quality, it isn't by shifting the burden of doing this onto patients to get them to act like better consumers and better shoppers who will then drive down costs. It's through institutions that engage in regular negotiation over prices. It's through the use of healthcare budgets that help to constrain healthcare spending. Now, within this, can the role, an enhanced role, an empowered role of patients improve quality? It almost certainly can, because when care reflects their values, it's going to be better care. But consumerism is somewhat problematic. We shouldn't be shifting the burden of reducing our healthcare bills and improving quality onto patients without institutional support. It just doesn't work very well as a market, and there's a long history of these kinds of discussions in the US. The other concern that we have, and again, this stems more from the work I've done with Karen Maschke on looking at medical technologies, is we also think that a certain version of consumerism has a threat of actually undermining professionalism. And here I guess we're at least in tension with Dr. Berwick's suggestion that it doesn't matter whether or not patients want something that the evidence doesn't support because it's such a value in and of itself. Here we are concerned about the idea that medical professionals shouldn't just treat customers like customers in any other sector, right? It's not like ordering up a burger and wanting it your way. You should actually pay attention to the evidence. You should be empowered to understand the evidence, which is complex and complicated and difficult to understand, and so better and more widely available tools that allow patients and their families to make informed decisions that reflect their values are important, but we shouldn't undermine professionals by suggesting that the customer is always right. Somewhere we need a balance between making sure that care is not dominated by professionals, not dominated by physicians, that consumers have a voice in their care and it reflects their preferences, and shifting all of the burden onto them. Thank you very much.
Good morning, everyone. I wanted to thank Health Affairs for inviting me to be here today, and also the support of PCORI and the New York State Health Foundation. I'm truly honored to be here because I get to share the caregiver perspective and the patient perspective on this subject. So my article in the Health Affairs is a narrative piece, "My Child is Sick, Don't Call Her a Consumer." And I'm at an interesting juxtaposition in terms of the way I view this. On one hand, I'm a professional in the field as a patient-family engagement consultant. I'm also a family caregiver to a chronically ill child. I'm also the spouse of a physician who's an adult medical hospitalist at a major academic center. So I have a number of different lenses that I could look through when looking at this subject area. And obviously, as my article states, I have some concerns about how we use this word consumer and how we look at consumerism in healthcare. Unlike other markets and industries, as others have said, healthcare is unique. We don't have the infrastructure that other markets have in terms of consumerism. And I would say we're woefully inadequate in that infrastructure. And we could just take a small piece of that, which would be price transparency, and there's been lots of discussions around that, given that hospital systems now are required to publish that information on their websites. But is that knowledge true power for the consumer, with lots of numbers that make no sense and lots of opaqueness in terms of how those prices come to be and what actually gets passed down? I think another thing that we tend to forget is, unlike other industries, consumerism in healthcare is quite different in terms of the relationships. In no other industry do we experience what we experience in healthcare, as well as the relationships we form as families going through the experience and with our care providers. And so to equate the same principles of consumerism on an industry that is so uniquely different is quite difficult, in my opinion. And looking at engagement, will consumerism really bring engagement of all communities? Consumerism is based on power and choice. And there are many marginalized and vulnerable populations in our country where that is not even part of their ability to pursue. So how do we take the tenets of consumerism and apply them to engaging all communities? I can tell you, in my own work in patient-family engagement, we really lack the diversity and having all voices at the table when we engage in this work. So briefly, my article talks a lot about, in the beginning, our family story. I am, as I mentioned, a family caregiver to a chronically ill child. My daughter, Aya, who's now 16, was born with a rare liver disease and subsequently went through many obstacles in her journey, including 2 liver transplants, which were 48 hours apart. And then she developed stage 3 Burkitt's lymphoma, a very aggressive cancer in which chemotherapy failed. And then she had to have an autologous bone marrow transplant. So as you can imagine, healthcare has been part of our life for many, many years. As I mentioned too, my husband is a physician, so I'm able to hear the struggles and the amazing work they do every day to provide care despite all the stress and pressures that are placed on them. And then our family has grown since then. My daughter, who is the oldest, Aya, has 2 sisters, a brother, and a sister on the way in 7 weeks. So I think as we use this term consumer, there's a few things we should need to keep in mind. Who is defining the term consumer? Is the system defining that term? Are researchers defining that term? Are health executives defining that term? And are communities, including patients and families, defining that term? What role does a healthcare consumer really want to play? Some want to be engaged, some not so much. Do they have the same access to the information they need, or do they not? And I think most important, who's actually accountable to the healthcare consumer? In the retail market, if you have a bad experience, you can go to the store manager. But when you have a bad experience in healthcare, who do you go to first? My own daughter, who's now 16, over the years, I've always asked her, why don't you speak to your care providers when you have an issue you want to bring up? And she says, they don't care that I'm here. They just want to talk to you, Mom. Can, as I mentioned before, our healthcare experience be considered in the same lens as any other consumer experience? Can watching my daughter lose her hair and her eyelashes and staying up with her at night and not knowing if the next day will come be the same as a retail, a tourism, or any other consumer experience? I don't think so. And then care providers. Are they going to change the way they provide care because now we are consumers? In my article, I bring up an anecdote where one of my daughter's care providers sat with us in our first oncology meeting when she was first diagnosed. And she asked me, can I sit in the meeting with you? She's known my daughter since she was born. She was her liver doctor. And I said, of course. She sat in the meeting with me and just held my hand. She didn't say a word. And every time the oncologist said something distressful, she would just squeeze my hand. Would consumerism teach her to do that? Or is that just an act of compassion? And we do it because we care. And again, I've mentioned infrastructure. I think that healthcare does not have the infrastructure that other markets or industries do. And last but not least, other sectors, if we're looking at consumerism, have continuous feedback, continuously changing their tools to measure the experience of their consumer. We are still just at the beginning of engaging patients and families in measuring things that matter to them. So if we are to start looking at empowering, we must look at the things and measure things that patients and families deem to be important to them and not just system needs. So lastly, I want to end by saying perhaps we look at this a little bit differently. Maybe not consumers, but partners. A partner has true power because we're an equal stakeholder. It's different than a consumer. A consumer is not necessarily an equal stakeholder. We are entrenched in the work. We work side by side as partners. It's an active role versus a passive role. And we're empowered at all different levels: systems, academic, research, measurement, forums, feedback. And we are leaders and partners in co-designing, redesigning, and building a new healthcare system. So I hope to leave you with this. I hope that we could look more to be as partners in this work and move forward in rebuilding our healthcare system. Thank you.
I want to ask a couple of questions that I hope any of you who want to respond will join into. It's not so much sort of one-on-one because there's so many cross-cutting themes. Holly, you ended with this concept of infrastructure, and it does seem to me that all of the papers took a different look at elements where it exists or it doesn't exist and what it takes to exist. And I'd like to focus on, depending on time, a couple of them. Excuse me, the first is this notion of integration, partnership, whether it's the workflow, which is a term used on the clinical side, whether it's meeting patients where they are, which is more how patients experience it. I just wonder if a few of you could weigh in on your sense of where we are in having the appropriate infrastructure or what steps are needed for the appropriate infrastructure if we're starting from the perspective of wanting to treat this patient-provider-clinician relationship more as an ongoing relationship and not just transactionally. So who wants to talk about infrastructure around building this into the workflow of treatment? Ming, you gave an example. Maybe you can build from there.
Sure, Ellen. Yeah, I think the patient portal is a tool to ensure that there is an ongoing flow of information both ways, basically. So it is a challenge to, I think, incorporate it into the workflow because, as you said, physicians oftentimes already have quite a demanding schedule. So it behooves on the care system in which they work to incorporate, to recognize the work that they do to respond to patient requests for information or providing information. And, for example, one of the organizations, they use clinical decision support that's generated by population health algorithms, so individual clinicians do not have to try to remember, which patient needs an A1C test on what day. But there are other challenges as a result of that because regulatory rules dictates that a computer can't just make orders. So it still had to go into the in-basket of physicians to authorize that. So while patients are quite satisfied with having access to the patient portal, allowing them to make appointments, pay bills, look up their test results, send messages and get response within 2 days, 1 day, some within 4 hours. But there is important implications for workflow, for resource, and for payers. This kind of work is oftentimes not paid for by payers. But this is something patients demand, and they differentiate that across systems. So it's not a simple task.
Karandeep?
Yeah, so I alluded to this idea that healthcare systems don't know what to do with patient-generated data. And it turns out that, from anecdotal experience, the time when you really need an answer to a question is often between the hours of midnight and 4 a.m. That's when you're usually most stressed out. And, so let's say you're checking your blood pressure and it's 200. You're checking your blood sugar and it's, 20. It's low. And you need answers. In some sense, healthcare systems, I think, are afraid to take in this patient-generated information whenever it's generated because it might be at 2 in the morning. And we don't have workflows. We don't have infrastructure on the health system side to deal with this kind of information at the timeline when it's relevant to patients. So I think some of what we have to adapt to is that we think of the patients we're managing right now as the patients who are admitted in our hospitals. But really the reach goes much far beyond that. And we have to, I think, redesign healthcare around meeting people where they are, but also when they need that help.
So I think if we truly build a patient family-centered care system, many of these issues would be addressed, and you'd also have the partnership of patients and families working on these issues. When we look at workflow, many of the tools we talk about, whether they're patient portals or the EHR, have not involved all stakeholders in building those systems. Therefore, we have issues with workflow. So if we're truly building a patient, family, and I will add community-centered care system, those are some of the issues that we could address and I think would help move us in the direction of building some of this infrastructure. But if we continue building tools where we're not including the user and the end user, and specifically that would be for IT tools, I think then we're missing the boat on some of the improvements we could make.
And if I could just, I think in addition to the kind of infrastructure improvements that we need within the hospital, within the health system more broadly to allow people to engage in a more timely way, it's important to think about changing the way we train medical professionals to think about their engagement with families and patients. So at the Hastings Center, we were involved in the creation of 2 online casebooks because medical professionals tend to think about case-based training, and so we found it useful. And it was primarily focused on how to think about taking in these different preferences, these different values, and negotiating with patients in a respectful way. And I think tools like that are needed as well.
Just one last comment on that is when you mentioned patient-reported information, So comments are patient-reported information. So anytime you post something online about your doctor, your dentist, or your eye doctor, or you answer a survey and you say something about them, that is information, that is patient-reported information that could be going back to the doctors, the hospitals, the health systems. And in some cases it is. Some of them do look at those comments, but the focus is primarily on reputation management right now, in contrast to actually taking in the information and saying, what can we learn from this? What does this tell us about our patient's experience and what we could be doing differently? And that is an area where I think we're starting to make some progress, but we're just at the beginning of that.
So I don't have a lot of time for questions, but I want to see if folks have some. I have more, but wait for a microphone, introduce yourself. We are recording, so I want to make sure we can get you on the record here.
Hi, my name is Nicole Braccio with National Patient Advocate Foundation. I have a question for Michael Guzmano. So I'm a pharmacist, and I really appreciated the comment you made about finding that balance between the patient and the provider and their care team in making decisions about treatment or what have you. So I wondered if you've done any research or if you have any opinions on like advertising and things like direct-to-consumer ads, because I find that that is certainly a source of sometimes confusion, also hope and relief, but I wanted to hear your thoughts on that.
Although it is amusing when the warnings last longer than the rest of the commercial. I think I'm glad you brought that up. I actually meant to say that in my formal remarks, because I do think in the context in the U.S. Of direct-to-consumer marketing, that is a major concern about the sort of concept of people acting like they're shopping around in other sectors without adequate information. And I do think there are tools, and we've discussed many of them here, for having conversations about trade-offs and important trade-offs that reflect the values of the patient and their goals that can be used, whether it's in-person speaking with clinicians, online tools, and others. But the way we're doing it now is deeply problematic.
Okay, I'm going to ask one more question, since Lisa, you in the wrap up to the prior question I asked started talking about everyone's comments are a form of reporting, and I thought it was very interesting your comment about sort of the use is primarily around reputation management. I'm going to have to remember that term. I guess the question I want to bring to you all is this notion of what sounds like a mismatch, but maybe a way out of this, and it comes up in a number of papers, not just the ones on this panel, around sort of clinicians' views of quality and certainly the clinical enterprise, how payers and government talk about quality and how patients experience the system. And it seems to me that in lots of parts of the economy, we have both technical, like safety standards for lots of things that you don't see a lot about on websites, and then you have patient experience or consumer experience, which is what tends to populate. So is there a way we can think, I'm aware that the historical view that the clinician knew best is part of the origin of shutting patients out that Michael mentioned in his piece. Is there a way we can sort of think of these as, instead of competing, as sort of two sides of the same coin, the more clinically oriented quality perhaps is defined in a more professional sense, and the more experiential role of the patient and how patients can learn from each other and teach clinicians about how to treat each other, and bring these together instead of thinking of them as competing worlds?
Well, I'm gonna promote Lisa's article with my colleagues at Yale, because I think they're on the right track and really show a way forward with this, and a lot of what they've written in the past does this as well. Because I think, as my colleague Deborah Stone has said over and over again, one of the problems we get into in policy debates is that you only value what you can measure. And I think one of the reasons traditional quality metrics have dominated from the professional side is that we have specific things that we're measuring: length of stay, mortality rates, things that sort of lend themselves to patient safety. And I think more creative ways of thinking about presenting patient narratives in systematic ways would allow us to bring this in to the measurement of quality and discussions around quality, where we can start to capture in more systematic ways the values of patients and the things they really care about.
Well, thank you for the plug. And I, just to build on what Michael's saying, I think part of what I didn't have an opportunity to talk about much is the idea of, in a perfect world, I think patients, some of whom are consumers, that's how I would think of it, would be able to have access to all of that information and use what's useful to them. My analogy to that would be, think about the last time you bought a new car or a used car, either way. And you get on these websites and it's pretty overwhelming, right? There's all this quantitative information that tells you about the car, but you can also read all about people's experiences with that car. Well, everybody cares about different things. So you may care about safety. You may just want to read other people's comments. Giving people the chance to me, part of empowering people as patients and as consumers is giving them access to whatever information it is that's going to help them move forward, whether it's making a decision, figuring out how to move forward with their clinician. So to me, they are two sides of the same coin, or they're one coin, and you have to look at all of those different facets because we all care about different things, and we can't decide for people what's most important.
So I'm with you on that, but I want to close by asking Karandeep and Ming, that's great for the patient, but then they return to a clinical setting and we're looking for some collaboration or joint decision-making. And so how do we close that loop, not just with structuring information for the patient consumer, but also to make it usable and actionable for the clinician?
So I think that, to answer your question, there are a number of tools that exist that support shared decision-making. I think some things, when people kind of read that or think about that, they think, well, I've never engaged in shared decision-making with my provider. Like, what are you talking about? So in a variety of areas, one prototypical example being prostate cancer treatment, for example, there is no one right treatment. There's a number of diseases and situations where there is no one right treatment, where you have to engage in shared decision-making process. And so in that example, there are tools out there like the personalized patient profile, P3P, which is gathering evidence to support the idea that instead of spending all that time in your office walking through the shared decision, you can give people a set of online tools, have them engage in that before they come to your office, and then that discussion is a lot more productive in the office because now they've already gotten that shared decision-making mind frame and training around some of the information, and you're having higher order discussions that might have required a second visit in person. So there are tools that exist, but I think that this is a ripe area to develop more.
Thank you, Alan, for this very provocative question. Healthcare is an experiential good. Patients and providers, they have repeat communication, repeat interactions, so relationship really matters, right? Patients would vote with their feet if they felt like they were not respected, they didn't feel compassion. So I want to build on what Kristin had said earlier about, what is real shared decision-making, and how do you promote that? And what does that mean to providers and patients? So if we ask physicians, oftentimes, about if they do shared decision-making, they all say, yes, of course we do, right? But then if you listen to audio or video recordings, it's all over the place. It's very broad variations. So patients have a goal for their journey, right? Patients want to have a good experience, but they care about their health outcome. They care about not having a heart attack. They care about, not having a stroke. But they may also care about their wrinkles. So I think it's necessary for the physician to lend their expert opinions and their knowledge into this shared decision-making. So I wanted to say, in our study that's currently in the field, We published a pilot study in Health Affairs in 2016. We're very happy to have funding from PCORI again to actually test how we can activate patients, coach them in doing shared decision-making, and at the same time, we will also offer safe space for physicians to practice shared decision-making, so we can see if they can actually meet during this precious time to understand patients' priorities, to understand physicians' knowledge base, and then to meet the patient where they're at. So we're hoping to see that by intervening on both sides of the stethoscope, that we actually put some structure into shared decision-making, and hopefully we'll have, we have outcomes. We look at not only patient-reported experience, but we will also look at their ability to follow through with decisions, first of all, their intention to follow through, and then their ability to follow through, and then we look at, after the indexed visit, how their use of services change, whether the volume of in-basket messages they send may change. So this is a great question.
Great. Last word from Hala.
I just want to underscore, though, it's key that we co-design these tools. Much of the shared decision-making tools were developed not in partnership with patients and families, and to a certain extent, not in partnership with frontline providers either. So I think it's important as we go through this discussion and we move through this journey that co-design and co-creation are really, really important.
Great. Please join me in thanking our first panel. We are going to move seamlessly to our next panel. I'll introduce our presenters as they come up. This is about the research enterprise. You're going to hear from Laura Forsyth, Director of Evaluation and Analysis at PCORI, where she leads a team that helps PCORI and stakeholders assess organizations' progress and make informed decisions about PCORI's approach to funding research. We'll hear from Consuelo Wilkins, geriatrician and clinical investigator and Vice President for Health Equity at Vanderbilt University Medical Center, and Jonathan Delman, Assistant Professor of Psychiatry at the University of Massachusetts Medical School. So I will turn it over first to Laura.
Good morning. Thank you. It's a real honor to open up this panel. And Hala, thank you. I couldn't have planned a better transition to this talk, so I appreciate your setting that up. So, PCORI is unique among clinical funders in the U.S. in requiring engagement of stakeholders, and particularly patients or consumers, in everything we do, and we apply that same standard to PCORI's work as well. So I want to begin by acknowledging the contributions of our Patient Engagement Advisory Panel, which includes patients, and also the members of our staff, the PCORI Board of Governors, and the Methodology Committee, because this was a real team effort. So I just want to amplify a few comments that you've already heard this morning about PCORI and our mandate, which is really to improve the relevance of scientific evidence for helping stakeholders to make their health decisions. And this includes patients, clinicians, insurers, and policymakers, people across the healthcare spectrum, to help them make better healthcare decisions. We do this by supporting and funding clinical comparative effectiveness research, or CER, to know what works best for whom based on outcomes that really matter to patients. And at PCORI, we talk about research done differently, and that really means involving these stakeholders in everything we do in designing, conducting, and disseminating research. And this approach really offers real promise for better aligning our research with the real-world needs and concerns of patients. And so PCORI's unique requirements and guidance offer a real new opportunity to understand how this engagement can contribute to research on a scale that's larger than has ever been done before. So we thematically analyzed 126 peer-reviewed articles related to PCORI CER projects that in some way talked about the team's experiences with engagement. And we use this new rich source of information about engagement really to look at three things. The first that I'm going to talk about today is how engagement contributed to the research. And then the other two things that you can read more about in the paper are really about the engagement approaches that the teams used to achieve those contributions, and also if and how the teams measured the ways engagement contributed to the projects. And so the authors of these articles really noted that engagement contributed to all aspects of the research, from deciding the study design, the outcomes to study, tailoring the interventions to meet the needs of the people receiving them, enrolling participants, and disseminating the findings. And I'll give you an example. Several of the papers noted specifically that the partners overturned assumptions about which outcomes were important to study. And I've included here for you just one example of how input from stroke patients really led to an overhaul of the research aims and data collection plan to align them with what patients really needed. And these authors also noted that engagement contributed in really 4 key areas: feasibility, acceptability, rigor, and relevance. Feasibility is about studies that are doable in the real world, having interventions and data collection plans that can actually be done, and mitigating real or potential roadblocks. Acceptability is about study designs and procedures and interventions that align with patients' preferences and needs, that are usable, and that have minimal burden. Rigor is about maximizing data quality and minimizing bias. And finally, relevance is about results that really matter and apply in the real world to the decisions that are being made. At the same time, a few of these articles noted the time and resources needed for engagement and acknowledged the trade-offs that engagement, along with other factors, can introduce in terms of feasibility, acceptability, rigor, and relevance. And there's always going to be these kinds of trade-offs as we design research studies. It's important to note that involving patients really enriches the conversation about what research matters and for whom. So, finding practices that improve the way that we design and conduct and take up research evidence is really an important health policy issue. And our findings today demonstrate how engagement can contribute to research that is more feasible, acceptable, rigorous, and relevant. And that's important because that's a really important step towards having research that better aligns with what patients and clinicians need. And it also matters because research resources are wasted regularly on things like low-priority research questions, inadequate study designs, or studies that will never finish enrolling their participants. So overall, our findings suggest the beginning of a shift from a research enterprise driven by investigators to one that more fully engages patients and clinicians. To maintain that momentum, what we really need is research funders and institutions to develop policies and to allocate resources to help us better support engagement on a larger scale. And we also need to advance how we study engagement. So we need to be able to move on to questions about how engagement contributes to the way we take up research findings and to healthcare decisions and outcomes. We need to develop new strategies for studying engagement and validated measures so that we can really understand these issues from multiple perspectives. We also need to get to a point where we can identify the critical elements of optimal engagement. And, it's clear from the work that we did that engagement contributes in a variety of ways. We also know that it's hard work and requires time and resources and commitment. And these findings, along with other evidence that's growing, really suggest that that investment can lead us towards research that is more useful and relevant for health decisions. And as you heard this morning, the road to more patient-centered health care really begins with more involvement of patients in generating the research and the information to inform that care. Thank you.
I'd like to thank Health Affairs, PCORI, the New York State Health Foundation, for the opportunity to present our work here. This paper represents a team effort with our Vanderbilt Recruitment Innovation Center, as well as our Vanderbilt Institute for Clinical and Translational Research, both of which are funded by NCATS, as well as our Vanderbilt Miami Meharry Precision Medicine Health Disparities Collaborative, which is funded by the National Institute on Minority Health and Health Disparities. The paper also represents a larger body of work that focuses on patients, participants, and communities as partners in research, and some of that work has also been funded by PCORI. What I'm going to talk about is a concept that we call return of value, and this has evolved from the concept of return of results. So return of results in the research setting is something that is increasingly expected from participants, although to date, much of this is actually focused on returning results that are actionable. And actionable from the standpoint of actionable in a clinical setting, not necessarily actionable or of value to the participant. So as we move to this and thinking about reframing this concept and considering what patients or participants might value, we've learned from our experience in multiple studies, but also in reading the literature, that participants want information about them. They want their data. So the idea that we are in research collecting thousands of different variables and elements and not returning it to them is one that many of them are concerned about. So as we attempt to really shift the field to this approach that we think is more person-centered, we really need to understand what people value, how they will use the information, and if they'll have resources available, what are the other unintended consequences or other consequences of sharing these results with them, such as the impact on clinical flow for their providers if there is information that's generated that might be relevant. So we designed a study that would actually elicit the perspectives of individuals across the country representing many different demographics. So we had a survey of more than 2,500 individuals. About 60% of them were women, and a little more than 60% of them were racial and ethnic minorities. They represent 49 states. You'll have to read the paper to see which one is missing. There's a beautiful map there. And what we found is that there were some important things that so we asked individuals to first rate on a scale of 1 to 7 the value of 12 different items. What we found there is that the top 5 things that people wanted to receive were results related to pharmacogenomics, their genetic risks of getting a medical condition, their lifestyle risks, how that impacted getting a medical condition, information about clinical trials near them, and the 5th on the list was how researchers are using my information. Important to note, in that list of 12 items was financial compensation. So in none of the demographics, when we looked at the subgroups, was money more important than information. So people valued receiving information, even if it wasn't data about them, more than they did financial compensation for the study. We then asked, of those 11 items, we took money out of this one, what is the single most valued item to you, and what's the single least valued? So in the graph that you're looking at now, you'll see that there are striking differences actually in what people valued based on their educational attainment. So for everyone who had some college or above, that yellow bar represents genetic risk of a disease. So in all of those groups, the single most valued item was information about a genetic risk of a disease. For people who had a high school education or less, they most valued connecting with others like me. So we have to really think about what that means and how to interpret that from the context of people who may be socially disadvantaged, and things that we presume they already have about knowledge or access to information about health conditions, whether or not they can actually understand and interpret genetic results. When we look at this based on by the race and ethnicity demographic, and by the way, we did ask only one question for race, ethnicity. It's a combined question, and people could select as many of those options as they would like, however they choose to identify. We did also see some differences, although for all of the groups except for American Indian and Native Americans, genetic risk of disease or something related to genetic information was still the most valued. So what are the implications of this? As we move towards, I hope, moving from just return of results to return of value, we have to again begin to think about what information would be relevant across large demographics of groups, but also making sure that we're not selecting information, data, or items to return that are only relevant to those who have the most resources. We must also consider, as we're returning information, for example, it's easy right now to actually provide individualized results based on pharmacogenetic information that's already available. We'll have to make sure that we're providing that in a way that people can easily understand it with additional resources, and if possible, access to genetic counselors who are socially, culturally competent and capable of communicating with them. Thank you.
Good afternoon, everybody. I really do appreciate the opportunity to be here. The slides, oh, next. There we go. All right. So I'm here to talk about how we can best, or how we can effectively partner with community members, particularly community ethnics, members of ethnic minority, ethnic and racial minority people, and people with serious mental illness, engaged in research as partners. And our study is a case study that really looks at the barriers and facilitators to just initiating the project, because in my work, I found that when people, researchers, jump into this from academia, these initiated partnerships can fall apart before they even get off the ground, and I'll talk about how that happens, often because of a lack of trust. I'm sure people understand why there might be some distrust from the community, and vice versa. So let's go to the next slide. So this was funded, and thank you, by PCORI, to the Cambridge Health Alliance Health Equity Research Lab. The principal investigator is Ben Cook at Cambridge Health Alliance, and I represent here a large group of steering member committees from Massachusetts that represent both patients, consumers, or as we might say, people with mental illness, in a person-first language approach, from different aspects of the community. So the study itself, next slide. The study itself is on how to assess patient and engagement of people from ethnic, racial minority groups who have serious mental illnesses and treatment. Because as we know, a lot of people from those communities don't trust treatment, don't know how to get there. So we have a study going on in that area. But the idea was really to make that study meaningful, and in order to do that, involving people in the community. So our approach is to go beyond basic engagement, which in my 15 years of experience in doing this work, have found wanting. I've tried this in many different ways, and I have found that if we really want to involve the community, we need to rebalance the power that is really held by academia in terms of resources, expertise, and holding the money. That automatically gives a group a great advantage, and the other group in the community doesn't necessarily want to participate in something where they have very little voice. So the issue here was to engage in a project that is community-based participatory action research, and I can talk about our case as I go through this, and this involves high levels of engagement. So you have to define your community here, and the community is here a identity, a unit of identity in the community. So in this case, as I said, in mostly the Cambridge, Somerville area of Massachusetts, people with mental illnesses who are racial, ethnic minorities. But how do you represent that group? And that's one real question. In our case, we go beyond appointing people to advisory boards. I have found that to be not good at rebalancing power. Academia still holds it. So the idea here was to contract with a community-based organization that represents people with serious mental illnesses to conduct that work. So that addresses the partnership issue, and that also addresses the community-based issue because that organization understands the community much better than the academic partners, who in this case had very little experience with community-engaged research. It's very challenging to start a community-partnered project. Everybody has to understand that from the beginning, and we all have to be pretty patient with each other. I'll address the barriers in a moment from the findings of our study. So what is the added value of CBPR beyond what Laura said? I would add that it provides a smooth and direct connection to the community. If you have an organization that's acting as a gatekeeper or manager and has experience in interacting with the community, it not only rebalances the power, but you have that quick connection, whether it be around collecting survey data, focus groups, or even just advice. The impact, and this is something that has been very meaningful to me. I should note that I'm also a patient or a person with a mental illness, and I was that before I had a PhD. But when you disseminate the findings and are trying to make changes, and the goal of CBPR is to try to change policy and practice socially, it really makes a difference on who presents the information. And I have seen when people from the community present their research findings and perhaps integrate their own story, I've seen policymakers be very moved and actually make changes. I can't speak to the project we're on right now, but I've seen that in the past. But that's the third advantage is it presumably can build capacity in the community to engage in research. So people develop knowledge, they're better able to partner as time goes on. All right, so now to the findings. The barriers fall into four categories. I won't go into this too much because I think they speak for themselves, but anybody who's done this work with communities that are disengaged knows that there's a lack of trust based on history, based on lack of resources, based on just a distrust of the infrastructure that treats them and at the same time researches them. So that's a given. Minimal resources to participate. We're talking about small organizations that do a lot of things, and the research might be a small part of what they do as an advocacy organization. They really have to think through how they're going to utilize resources to participate. And the academia, of course, has a lot of more resources. Number three is the stigma and discrimination that people have to deal with. Academic researchers also are not quite sure what they're getting into, and most of the time, and wonder if it's worth doing. And this wasn't a barrier in our case. This is a facilitator in our case with our Cambridge Health Alliance team. But many researchers are focused on publishing papers and less so on making a difference in the community. You need to have that belief system in you to take the time to engage with people. unclear partnership decision-making protocols. There's a lot of decisions that have to happen. Do everybody have to be involved in the same decision around how you analyze data, how you make decisions about measures? So that should really be thought through. It wasn't here. I'll show you how we overcame that. And the complexity of research can also get in the way. Okay, I'm going to wrap up by saying our facilitators fall into 4 areas, all based on group dynamics. Group dynamics determine how this initiation of project can work out. So as I said, we have an established community organization that acts as a gatekeeper. The CBPR consultant was me, but because people had little knowledge of the project, I was able to bridge a gap between the community and that. In the funding and time, don't underestimate the amount of time to the community to participate. $20,000, $30,000 for them to really bring people, for salaries, for them to bring people into the project and attend meetings. The leadership, the PI, the director of the CBO, are people who want to work together. They're not, they really want to include other people and see the value in the project. Structurally, regular team meetings, and training for the community on research. I've done a PCORI project where I did an online training for this. It's not rocket science. There are some basic concepts people can learn to participate. And co-learning, this is probably to me the most important thing because it allows the academia and consumers to sit down and get to know each other, talk about their different levels of expertise, and the researchers begin to see the consumers more as people. And they begin to realize why they got involved in the project. And they're talking about very sensitive topics around racism and stigma. Finally, there's a relational piece where people have to be respectful of each other. It's interesting to see how this sometimes doesn't happen, but in our group we had a lot of these principles laid out, but these were the facilitators that really allowed us to jumpstart the project, and now it's going well, and we have findings in the process coming out with the research. Thank you very much. Sorry.
This was very interesting and reminds me that the platform on which all of the engagement that we're looking for here is evidence, and so this is sort of the beginning of the story, and if you get the beginning wrong, you can never catch up. I'd like to just ask about how we think about the heterogeneity of consumers. It's great to talk about consumers, but as is clear from the data presented here and some from the prior panel, as we would expect, consumers vary along a lot of different dimensions. They vary in the power relationships, and they vary in their preferences. So let me just ask, Laura, when you're looking at the portfolio for PCORI and you see these types of engagement and the different ways consumers are involved, which is the entire spectrum, how are you also thinking about whether or not the people who are involved are, in some sense, how do you even think about representativeness when you're talking about consumers?
It's a great point, and they do have a whole variety of perspectives and needs, and we're really taking that on in a number of ways. One issue that we have to think about is from the start who we invite and how we reach out to people, and so it's clear that from the perspective of the researchers, of the partners, of people who want to be partners, that we've got to develop and support additional ways to bring in a variety of people and give them access to being partners on the projects. We are developing trainings and working with partners to help them be able to represent not just their individual views, but challenges that are relevant to patients more broadly. And also, I think our investigators are learning on the job, and we are starting. We're starting new things, and so we've got a variety of projects in place to try to learn how do we do this well. And it's a challenge that I think we're all taking on together. And I think it's important to note too that even in light of all of this heterogeneity, we are making progress towards better aligning our studies with things that, with the factors that matter most to patients and clinicians. And so if we can continue to do that and think about more models and ways to bring in people to the process, that we can do that. I don't think we expect any individual patients to be able to ultimately speak for the entirety of all patients.
Consuelo, do you want to weigh in on this? You've got this, the national map in the paper. Again, that's one definition of heterogeneity is geographic, but you looked at it along a number of other dimensions as well.
Yes, so I think we have to accept the heterogeneity of the human race as part of what we learn from. I think if we're looking at specific health conditions, though, there are often more similarities among those experiencing a health condition than there are differences. And I think as we begin to capture those perspectives, we shouldn't be expected to tailor things to each individual difference, but look for those commonalities. And I think the more important perspective is to make sure that the researchers and the healthcare professionals' perspectives aren't the ones that are driving all of the work.
And Jonathan, you worked with a community-based organization, but again, within the population, there is also heterogeneity. You did mention it's a disproportionately underrepresented minority population, but still, how do you think about that? Even when you get to that subset, there's still subsets within.
Yeah, the community-based organization, myself, and I think Cambridge Health Alliance considers this long-term work, and that you're initially doing an assessment and really trying to learn about your community, and then as you learn things, you learn who you're missing. And in relation to this, the Transformation Center, the CBO, got a Tier 1 grant to look at the research preferences of African Americans living in our area. So we see this as a constant need, and the Transformation Center has ongoing processes in place to assess need. In 15 to 20 years background in this area of assessing priorities among people with mental health conditions.
I think I can squeeze one question in, but it's going to have to be quick with quick answers. So let's get a microphone to you. And
hi there, Charlene Wong from Duke University. I had a question mostly for Consuelo, but also perhaps others would have comments. I'm working with Verily Life Sciences in the Project Baseline study, where we're also returning research results and aim to return value. A question as we think about engaging people more in research is, we found a challenge because we've already been returning results in walking the fine line that can exist between research and clinical care, particularly when you're returning clinical research results. And just wondered if you guys had comments on that.
So I think that is a very important concern and perspective to bring up. I'm a little bit familiar with Project Baseline, but I don't know if the clinical results are being done in a CLIA-certified lab and environment, so there are lots of things from the regulatory standpoint to consider. I think in what we've learned, not just in the work that was presented today, but in community engagement studios that we did all around the country, is that people still want those results, and they need to be contextualized. So if there are potential clinical implications, they need to understand what those are. And I think what we're still missing, though, is how to really connect that information to their providers and the clinicians who are going to be presented with just the drop of all this research information, not sure what to do with it. But I do think it's important to make that distinction between what could have clinical relevance but is still research versus these are clinical labs that are being done in the setting of a research study.
Yeah, just with community-based participatory action and research, you're trying to build capacity in the community to not only conduct research, but to understand research. So it is the CBO, along with academia, that could help people learn how to interpret findings. We shouldn't be hiding people from things, but we can educate them. And we have to trust that people, I think, in this country or in this world can manage it.
okay, well, please join me in thanking our panel. Okay, we're going to move into the second half of our morning, which has 3 panels that'll all be back-to-back. We have 3 papers that look at consumers shopping for care, making price-sensitive decisions. You're going to hear from Ativ Mehrotra, Associate Professor of Healthcare Policy and Medicine at Harvard Medical School and a hospitalist at Beth Israel Deaconess Medical Center. You'll hear from Ben Chartok, a PhD student in the Healthcare Management Department at the Wharton School and Associate Fellow at the Leonard Davis Institute of Health Economics, and from Jeff Kullgren, Research Scientist in the Center for Clinical Management Research at the VA Ann Arbor Healthcare System, and an Assistant Professor in the Department of Internal Medicine at the University of Michigan Medical School and Institute for Healthcare Policy and Innovation. I'll turn it over first to Ativ.
Well, great, thank you. We're going to change gears a little bit and talk about consumerism. I want to acknowledge my co-authors and the Arnold Foundation for this work, which is about paying patients to switch. So as all of you are likely aware, there's wide variation in prices across the healthcare system. Even within a given market, you can see 5-fold differences in the price for what appears to be the same service at the same quality. And that has created what health plans and employers have seen as an opportunity. We could save a lot of money in the US healthcare system if people switched where they got care from higher price to lower price places. There's been driven a lot of interest in, well, high deductible health plans and price transparency initiatives are ways to potentially encourage that sort of price shopping. But unfortunately, they've had little success. And so now employers and health plans have turned to new ways of trying to have patients switch in the forms of new benefit design. And I'll be speaking to you about one of those new forms of benefit design, which is rewards programs. So just showing you a number of the national health plans as well as local health plans have created such programs. This is Compass Smart Shopper, and Kaiser Health News has also described how a number of plans have switched patients to getting cash back for switching to care. How do these programs work? What they do is they focus on a series of what you might term elective or shoppable services. So things such as a lot of imaging services, MRIs, CTs, mammograms, ultrasounds, endoscopies, things like a colonoscopy, as well as minor, as well as major surgeries such as a hip or knee replacement. Now, you don't get a reward for just going to one of those providers. What you first have to do is you have to call an advice line or use a dedicated website to identify the lower price provider. And then if you then go subsequently to that lower price provider, you get a check in the mail, anywhere from $25 to $500, depending both on what service we're talking about as well as the relative price of that service. So if it's a very low price, you get a larger bonus. Now, one of the really unique things about this is that it builds right on top of the benefit design. So you might have this unusual situation where you get a $100 bonus check to go in for a lower priced MRI, but you also have to pay $200 because your co-insurance or your deductible requires that. And it's interesting how that plays out. Well, there's a lot of enthusiasm. A lot of people are interested in these plans. How well do they work? To our knowledge, no one had investigated the impact of these, so that's what we tried to do in this piece. What we did is we partnered with HCSC, which is the 4th largest national plan in the nation, and they had introduced this rewards program in 2017. We identified 29 employers who had around 270,000 employees and dependents who were part of that program. And then we identified a group of employers who introduced it the next year, in 2018, who had a similar number of eligible enrollees. What we then did is we compared the differences in care prior to the introduction of that program, 2015 and 16, to the first year of the program in 2017, between these two populations. We wanted to see how many people were engaged in the program, as well as the average price that was paid for the services that were eligible for these rewards, what fraction of all the services that were provided were to one of these lower price providers, and how much care did people get, utilization of these types of services. Our major finding is what we found on the impact on prices. Across all people who were enrolled into this program, we found a 2.1% reduction in price relative to the control population across all of these services. This was primarily driven by the imaging services, with MRI in particular, but mammograms and ultrasounds where we also saw this. Interestingly, we found little to no effect among the more invasive procedures, endoscopies, minor and major surgeries. Now, I should emphasize this is the difference in price across all people who were offered the program. Only about 8% of people who were enrolled in the program actually went to one of these websites before they got care. Among that 8%, the savings were much larger in magnitude, but at aggregate over the whole population offered, it was 2.1%. So to summarize, we found interesting results with the introduction of this new program. First, modest engagement with the program. I said again, 8%. The savings for the health plan and the employers were modest. That 2.1% savings in price translated into $2.3 million in savings. The employer and health plan gave out $200,000 in bonus payments to patients, so $2.1 million in savings, or about $9 per member per year. Again, as I noted before, the savings were mostly focused on the imaging services, in particular MRI, mammograms, ultrasounds. So in summary, I think these results, as employers and health plans are looking for new ways of moving patients, encouraging patients to switch to lower price providers, rewards programs is added to that list of different programs that might be effective. I think we have to be very cautious about in terms of expectations. The savings here were very modest in magnitude, but at least is something that has, in our results, was effective. So thank you.
Hi there, my name is Benjamin Chartok, and I'm going to be talking about consumer responses to surprise out-of-network medical bills in elective situations. This work is joint with my co-authors Christopher Garman and Sarah Schutz. So we're going to be talking today about surprise out-of-network medical bills in elective situations. Surprise out-of-network meaning when a patient goes to an in-network hospital, sees an in-network primary care physician, but nonetheless is treated by an out-of-network other provider, an anesthesiologist, a radiologist, et cetera. And if we think about consumerism in patients and shopping, given a particular procedure, a particular episode of care, the patient is it's virtually impossible for this patient to shop to seek in-network care if they don't even know who the anesthesiologist, who the radiologist, who the other provider will be. But in elective cases, the patient has the opportunity to vote with their feet in subsequent episodes of care. So what we study is switching facilities to another hospital after receiving a surprise out-of-network medical bill. So we really want to understand the consumer response and what are the consequences of that response. So what's our data? We look at a nationally representative healthcare claims database with mothers who have exactly 2 births between the period 2007 to 2014 for one of the 4 most common labor and delivery procedures, who do not switch MSAs between birth, and who have more than one choice of hospital at the second episode of care. Now, thinking about opportunities for shopping after a surprise out-of-network bill, we can think of other elective cases where these results might also be relevant to, such as a hip replacement or a knee replacement, other shoppable episodes of care. And how do we identify a surprise out-of-network bill? Well, we use the methodology and the taxonomy that my co-authors and I, as well as other co-authors, have developed, where we take claims data that has an in-network indicator and find exactly line by line, claim by claim, when episodes of care are in-network at the hospital facility payment, in-network at the level of the primary provider of care at that service, and out-of-network for another ancillary physician. So what did we find? Was there increased switching associated with surprise out-of-network medical bills? Well, much like going to a restaurant and getting a bad meal, we did find that there was increased switching after a surprise out-of-network medical bill. So we found that a mother who received a surprise out-of-network medical bill on their first birth had 13% higher odds of switching facilities for a subsequent birth in comparison to mothers who did not receive a surprise bill on the first birth. And furthermore, this switching was actually an optimal policy for these mothers. So they were better at avoiding surprise out-of-network medical bills in the future compared to mothers who did not switch. We thought these findings were interesting, and I'll tell you why and kind of where we think the implications go to all elements of the healthcare system. So first of all, we think these findings are interesting to patients. Patients are those who could be particularly harmed by big bills that they otherwise wouldn't have expected, that the network design kind of prohibited shopping for in the first place. And where our results show that it may be that patients are choosing optimally to respond to these surprise out-of-network medical bills when it's particularly financially harmful the first time around. So as someone on an earlier panel said, patients, consumers can kind of shop with their feet, vote with their feet. Second of all, I think the results of this study are very important to policymakers who are beginning to debate patient protections for surprise out-of-network medical bills, both at the state level but also at the federal level. Most of these regulations are those that hold patients harmless when they cannot possibly shop or anticipate for out-of-network care. We think that under protections like these, patients do particularly well. They're particularly well protected. This is important for insurers and for healthcare providers as they come to agree on what appropriate in-network rate of payment should go from the insurer to the provider at episodes of care. And interestingly, we found these results were important to hospital managers. So typically we think of surprise out-of-network billing as an issue focused between the insurers and the doctors. But here, given that the childbirth is often the first experience with the healthcare system for expectant mothers, we found that patients really can voice loyalty, can switch from being a lifelong customer at one hospital to another. And so we encourage hospital managers to kind of take advantage of the loyalty that's established and think of a surprise out-of-network medical bill as another attribute that they should care about. So one thing to kind of couch all these results in is that this is shopping that happens on the basis of elective procedures. We can't say that this is shopping that will occur on emergency procedures, which have even higher rates of surprise out-of-network billing than elective cases. And so in some sense, it seems to me to be a little bit of an upper bound of what the shopping and the reputation and the consumer market can do on its own. So it really highlights to me how there is in this market failure of patients not being able to anticipate and know and shop on their network design. It's a complement to the shopping, and consumer protections are complements to one another. They help kind of ease the consumer experience with surprise, unanticipated out-of-network medical bills. So thank you very much. Appreciate it.
So I'd like to first thank Health Affairs, thank my co-authors, and also thank the Robert Wood Johnson Foundation for funding this study. So nearly half of Americans who have private health insurance are now enrolled in a high-deductible health plan. And as Alan had said in his introductory remarks, whether we think this is a good thing or a bad thing, we can all agree that these kinds of plans encourage enrollees to be more discerning healthcare consumers. We know from our previous work and from the work of many others, however, that very few high-deductible health plan enrollees are engaging in some key consumer behaviors, like using price information in their decision-making or talking to their providers about the costs of services that they may need. So in our study, we surveyed 1,637 Americans in high-deductible health plans about factors that may predict, facilitate, or impede their engagement in consumer behaviors, so that you could potentially identify some key opportunities for new strategies that could be explored to advance consumerism in high-deductible health plans. So on this slide that you can see from our survey, the percentage of Americans in high deductible health plans that have engaged in one of the 5 key consumer behaviors that you can see on the slide in the last year. And then again in our survey, we looked at factors that were associated with engaging in these behaviors. Among people that had engaged in these behaviors, things they said helped them be able to engage in the behavior. And among the many more people who had not engaged in these behaviors, things they said that impeded their engagement in those behaviors or stood in their way. We found, for example, that having a health savings account was associated with saving for healthcare, and that employer contributions to an HSA were the most common facilitator of such saving. Many of you are well aware that many high deductible health plans are eligible for linkage to an HSA, but many people who are enrolled in high deductible health plans do not necessarily have a health savings account. So just to explain that difference. We found also that high confidence in being able to discuss costs with providers or trying to negotiate prices was associated with engaging in these behaviors. And someone in the doctor's office, somebody from the health system, was the most frequent facilitator of discussing costs or trying to negotiate prices for services. We found that higher financial literacy was associated with comparing prices, comparing quality information, and web-based tools were the most common facilitator of engaging in these behaviors. Importantly, for each of these consumer behaviors, among the many people who had not engaged in one of these behaviors but were enrolled in a high deductible plan, the most frequently cited impediment was not having considered engaging in these behaviors when making healthcare decisions. So these results together suggest some strategies that health plans, employers, and health systems could potentially explore to promote greater engagement in consumer behaviors among the growing number of patients who are facing high cost sharing and high deductible plans. Opportunities for employers, for example. They could more consistently provide and contribute to a health savings account when employees are enrolled in high deductible health plans. They could also implement programs to increase health insurance literacy as well as financial literacy. So opportunities to help people better understand the plans that they're in and better use their money when they're having to pay out of pocket for many of their healthcare services. Health plans could educate plan members about the benefits of engaging in consumer behaviors. One other thing we found in our survey is that another frequently cited reason for not engaging in these consumer behaviors was that people felt like it wasn't going to help them all that much. So we have found in previous work, though, that about half of people who had engaged in one of these behaviors either felt it helped them get a needed service or pay less for their care. That's something that health plans could more consistently educate plan members about. They could also potentially help plan members learn new care-seeking skills and have different habits when seeking health care, especially helping plan members be able to effectively, consistently, and confidently communicate with their providers about the cost sharing that they have in their plan and talk with them about the costs they may face for services they need. And that could also be helpful in helping people think about and potentially try negotiating prices for services, again, when they're having to pay for very expensive services out of their own pockets. And then finally, opportunities for health systems. They could, I think, do a lot to more consistently encourage conversations about cost between providers and patients, educating providers and other workers within the health system to help people navigate the challenges of the high cost sharing that they face. They could also much more consistently make prices, the true prices that patients, the out-of-pocket costs that patients are going to face for services in high deductible plans, making those prices available at the point of care. We have a lot of information available in electronic health records. I'm a primary care physician. We have a lot of information to help make good decisions for an individual patient about their health needs, about their allergies, about things that they've tried and not tried in the past. One thing that we don't have is the price that that individual patient is going to face for a service. And that's information that health systems could more consistently be providing at the point of care. And they could also be training clinical staff to use these prices when making care plans, not just healthcare providers, but other parts of healthcare teams. So thank you, and I look forward to your questions.
I'm going to ask a quick question of each of you. Ativ, when we've looked at, and you're very familiar with literature around methods other than the direct payback like reference pricing. The target in those examples is not just the patient to make a better choice, but often it sends a signal to the provider, hey, if you want to be on the low tier, if you want to get patients, you maybe need to move your price. So I wondered if you could talk about the provider side of this equation. I understand it wasn't integral to the program, but was there any, are you aware of any engagement with providers, any provider response?
So I think we're, is this on? So, really interesting question. So in prior work that's used in other forms of benefit design, just to flesh out Alan's question, for example, with reference pricing, we found that the providers in those communities, in some cases, did start dropping their prices due to competitive pressures. In this particular case with these rewards programs, I think we're just way too early for this. And also we have to acknowledge that in those situations, a large fraction of the patients were subject to that benefit design. In this particular case, even though there were a lot of people, they were scattered all across the country. So an individual provider may not even notice that some of their patients are part of this rewards programs and switching out. So if these programs become much more widespread, and then I do think we'll start to see that. We did specifically look for it here, and we did not see any changes.
Thanks. Benjamin, you concisely presented the odds of changing, the odds of surprise going down by 50% for the second time. But just for the benefit of the audience, can you put some numbers on how frequent this is in the first place? Because that is critical to interpreting the change in the odds.
Sure, absolutely. So the odds of a surprise medical bill on a labor and delivery are 11% for the employer-sponsored insurance population, about 1 in 10. It's a little bit lower than the odds of a surprise out-of-network bill for an emergency episode of care, but higher than some other procedures. So this is switching on a baseline of 11%.
And so when you show 56% decline for the second for those who switch?
That's on the 11% baseline.
I want to make sure everyone got
Yep.
that. Thank you. Jeff, striking, in Ativ's comments, you talked about modest effects, but it was only 8% who engaged in the tool. You said the most prevalent reason for not doing these behaviors is you didn't think of it. So I was struck, if I remember right in the paper, people with chronic conditions don't have significantly higher rates of these behaviors than those who don't, and one might imagine that since most people are mostly healthy most of the time, they wouldn't think about this, but if you have a chronic condition, you might come back to this issue, someone might encourage you to. Any thoughts on that? Did I get the finding right, and any thoughts on the implications of that?
Yeah, that's correct, and that's a great question. So in our survey, we did in fact hypothesize that people with chronic conditions and also people with relatively lower incomes might be more likely to engage in some of these behaviors because they do face a disproportionate burden from the high cost sharing and high deductible plans. We found, however, that those individuals were equally as likely, or not likely, depending on how you look at it, to engage in the consumer behaviors we looked at. I think just one other striking finding that I'll add to that is we also in our survey included a measure of how often consumers shop for other kinds of goods other than healthcare. So are you somebody who's a bargain shopper who clips coupons and things like that and searches for sales, or are you somebody who just kind of takes the price and needs something and goes to get it? We found that even among people who were very savvy shoppers for other kinds of consumer goods, that the vast majority of them had not engaged in one of these consumer behaviors, and I think relates in part to perhaps people not considering doing so when seeking care.
Thank you. Do have some time for you all to jump in with some questions. We'll start right here. Wait for a microphone. It'll take just a moment. Get to you.
Hi, thanks. Alwyn Castle with Policy Translation. My question is for Benjamin. And I'm interested in how, I haven't had a chance to read your study, but in my experience, most women choose their obstetrician rather than their hospital, and you get the hospital that your obstetrician practices at. Were you able to unsnarl any of that in your study? Because I suspect that is in the background.
Yeah, that's a great question. So we used the primary physician identified in the database which is typically an obstetrician. It's never a ancillary provider. And to identify a surprise out-of-network bill, we had to think about cases where both the primary physician and the hospital were both in network. And typically, both from anecdotes and also from our research experience, we found that a lot of these surprise out-of-network bills don't come from the obstetrician who is selected by the patient. They come from someone outside. But in a typical labor and delivery, like any other form of care, very many doctors do see the patient, and so there's a lot of different opportunities for a surprise out-of-network bill to occur.
I guess maybe I didn't ask the question.
Sure.
Enough, that is that, did women change their obstetrician?
They changed facilities. So we have a masked facility identifier, so we don't know if it's Georgetown MedStar or somewhere else, say, for example. So we just know the change of the facility. Yeah, correct.
Yes, right here.
I'm Dr. Caroline Pomplin. I'm a primary care physician. I have a question for Jeffrey. Say you had a child that was born with type 1 diabetes, or, and that's, for now, that is, we can manage it, but we can't cure it. Or you had a child with asthma, or something like that. How important, and say you're not rich, how important would price be in selecting a provider?
Yeah, well, that's a great question, and I think that illustrates a challenge that a lot of people with chronic conditions or family members with chronic conditions face with a growing number of people who are enrolled in plans with high cost sharing. I think your question highlights that's going to be depending on somebody's individual insurance coverage, their means, their preferences. I will say that. Diabetes, asthma, other chronic conditions that require regular routine care, as well as a pretty clearly defined set of services that one is going to need, is a potential opportunity to help patients who face high cost sharing get the care that they need at a more affordable price. I'm an internist, and so I treat, for example, a lot of patients with diabetes. And that's a great example because no matter whether one's diabetes is well controlled or poorly controlled, there's a pretty standard set of services that patient will need over the next year. Now, when that individual is in a high deductible health plan, it's very likely that they will have to pay for many of those services out of their own pockets. And that may be an opportunity to help people find more affordable places to receive care.
I just wanted to add one thing building off of that question, which is, and also going back to the first panel, which talked about should patients be consumers, where this is a very strong contrast between this panel and so forth. And I'm a little bit worried about sort of a dichotomous or binary thinking. Hala was very eloquently describing the experience of her own daughter. She should not be in any consumerism or high deductible health plan product, as is many patients who shouldn't be, who have chronic illnesses. That's at least my perspective. But there are a lot of people who are very healthy who, for these types of benefit designs, high deductible health plans, rewards programs, shopping, may be very amenable. Like, it would not make sense for my liver transplant to shop on price. However, if I have sinusitis and I just need to get it taken care of, I think patients in our interviews and our work, and maybe in Jeff's work also, are very amenable. They're like, yeah, price matters a ton. And so we have to not think consumerism versus not consumerism, but I think, at least my own view, is think about which patient population is these kinds of efforts amenable to, and maybe certain populations where we should not be putting there. I think sometimes we, again, think black and white in this area.
Right here. Wait for the microphone.
Eric Ellsworth, Consumer's Checkbook. One thing that I think is a big driver of cost transparency that I don't see a lot of discussion of is the coding room. Where an actual service that's delivered gets coded, usually fairly remote from the physician, and then handed over to the insurance company. And that's where a lot of the non-transparency actually takes root, because you don't know what they're going to code for, and you don't know whether they're going to code the same thing for each insurer. So how do we kind of bring that into a more open and transparent state?
I guess that's a terrific question, and I think speaks to some of the challenges, especially, say, within health systems, where you may have a billing department that knows very well what particular code and what price has been negotiated with a particular health insurer. and the actual point of care, the patient experience in terms of not having to know which CPT code they're going to need, for example. I guess I would look, and I would love to hear the thoughts of others on the panel, I would look to some examples where stakeholders have figured out ways to do this. I think one great example of this, for example, is the websites available in New Hampshire from the state government. Ativ, I know, has studied that well, where a consumer can go in or a patient can go in and they can identify the health insurance plan they have, the service that they will need. They do not need to know, as best I can recall, the CPT code. It's in more kind of intelligible terms. I need an abdominal CT or a knee MRI. And they can get there an estimate for what they would face out of pocket across different kinds of health systems. There does need to be more efforts to translate what goes on in billing departments into useful information for patients. I don't know, Ativ, if you want to add to that, or Ben.
Yeah, no, I think if we were to take the literature out there in terms of price transparency initiatives where you're trying to figure out the price and the out-of-pocket costs you want, we haven't found those are very successful. Well, these such a benefit designs have been more successful. I think your question kind of hints at least my own view on why there's that difference. I published a piece where I described the experience of myself shopping for my daughter's minor eye surgery. I'm a doc, and I'm a health policy expert who studies price transparency, and it was very, very difficult to navigate the CPT codes, the facility fees, the professional fees, the post-op visits, et cetera. It is impossible to navigate that complexity right now, I think, and some others have described that. While I feel that some of these benefit design packages have the advantage, in terms of one advantage they have is that make it a lot easier. It's not, oh gosh, I got to figure this whole thing out. It's, okay, that place I get the reward, or that place is under the reference price, or this is what I have to pay under a tiering product. It translates this extremely complicated system and makes it a more easier interpretable decision by the patient. And so I think that's one thing that I think we need to think a lot about is why do we throw people out into the wilds of CPT codes and facility fees when it's very difficult for them to get around and interpret that information?
I'm going to take another person here. Yeah.
Thank you. Dr. Robert Burney, I'm a retired provider and consumer, patient now. You guys are all looking to patients to make decisions. That's naive. I would look to my insurance company to send me a letter. Dear Dr. Burney, you are going to have cataract surgery. Here's a list of 5 places where you can go and have that done. And the second column has your out-of-pocket expenses at each one. Your choice.
Yeah, I'll take this. Yeah, I mean, there are certainly insurance companies that are thinking about ways to simplify the process on behalf of the consumer. One proposal for surprise out of medical bills in particular is bundling emergency care, so that requiring that if a hospital is in network, then all of the providers who are working there in network, and that can simplify for the patient the experience and kind of almost do the insurance design up front, taking out of the at the point of care shopping aspect. But there are always going to be elements of care that involve patient decision making on the margin. And I think, one thing that I've learned through this research agenda is it's really a partnership between the insurers, the providers, as well as the patients in making these decisions.
So I'm going to take a last question right here in the middle. Again, if you can wait for the microphone.
Thank you. A question for Ativ. My name is Lee Rucker, Enhanced Value Policy Consulting. Is the goal of the rewards program to ensure preferred price or to ensure preferred price on an appropriately indicated service? For example, with MRIs, which have been considered overused, is there a pre-step that the consumer patient has to go through to ensure that they're appropriately channeled to an MRI versus an X-ray versus no radiologic intervention at all? If you could discuss that, please. Thank you.
Right. So the rewards program is really focused, in my interpretation, just simply on moving people based on their price and giving patients some of the savings back as a carrot to do so. You've raised a really critical point, which is, well, did the MRI, was it even necessary or not, and how does that play a role? That's something the rewards programs have not addressed. One point that I might make, but that's also a larger healthcare system problem. And so I would view that as something else. The only thing else I would add is one interesting finding from our work was that we were Economists might worry that, hey, if you give people a reward, will they get more care than they need? We did not see an increase in utilization. If anything, we saw a small decrease. And it's hard to know what that is caused by, but one thought is that when you go to this website to get the $100 reward for the MRI, you're like, oh, I'm gonna have to pay $250 out of pocket, and that might discourage you from getting care. Now, whether that's care that you should get or not get is also another question, but I just wanted to at least highlight that point.
Okay, well, if there's one thing we've established is we do understand why not having considered engaging in these behaviors is one of the top reasons people don't engage in them, because they are complicated. Please join me in thanking our panel. We are going to move seamlessly into our next panel, which is going to talk about health plan design, the role of the insurer in insurance design. Just to keep us moving, I'll go ahead and do the introductions as folks are coming up. We'll hear from Frank Wareham, Associate Professor of Population Medicine at Harvard Medical School. We'll hear from Betsy Cliff, doctoral candidate in the University of Michigan School of Public Health, Department of Health Management and Policy. Susan Perez, Assistant Professor at California State University, Sacramento. And Madhulika Vulamiri, a Senior Medicaid Strategist at the North Carolina Medicaid Program. So I'll turn it over first to Frank. Should have brought us up to the, just be patient with it.
Great. Well, good morning. I'm Frank Wareham, and I'm going to be talking about vulnerable women, high deductible insurance, and breast cancer care this morning. So I'd like to acknowledge and thank my co-authors who are listed there. Also like to thank Dr. Weil, Dr. Haddad, our editor, and the staff here at Health Affairs for organizing this event. And this work was funded by the National Cancer Institute. So we've heard about high deductible health plans this morning, and high deductible health plans are plans that have cost sharing in the range of about $1,000 to $7,000 per person, and they are intended to incentivize patients to, to shop for care and shop for higher value care, but critics fear that the opposite will happen. And so high deductible health plan growth has been rapid. You can see on the graph there that between 2006 and 2018, high deductible health plans went from 10% to 58% of the employer-sponsored insurance market. And so our group has previously studied high deductible insurance and breast cancer and found that there were delays in care for important breast cancer services. However, it was uncertain and unknown about whether women who are more vulnerable, for example, low income, living in rural areas, would experience greater delays in care. So the goal of our project was to understand whether these delays that we've found are more pronounced among lower income and other vulnerable populations of women. So I show this slide because these plots illustrate both what we studied and how we studied it. So these are plots of actual out-of-pocket, all medical out-of-pocket costs among our two study groups. Women who were switched by their employers to high deductible health plans, and women who remained in traditional, more generous, low deductible plans. And so you can see the red line is those are the costs of the women who switched into high deductible plans. And you can see that at the point of that switch, they experience a very sudden, very large increase in their out-of-pocket costs. And then the women who remain in low deductible plans have costs that are much lower relative to the high deductible. So these would be increases of about 50 to 70% over a 4-year follow-up period. And on the left of the slide, this shows the out-of-pocket costs for low-income women, and on the right, it's the out-of-pocket costs for higher-income women. And we used health insurance claims data from a national source with representation in all 50 states to study this. So, and these are our results. So in other words, what happens to breast cancer services when these low-income women are switched by their employers to high-deductible health plans? And you can see, again, some plots here. These are plots showing the percentages of women who experience various breast cancer services. So breast biopsy for diagnosis, early stage breast cancer, and chemotherapy initiation. And so you can see that low-income women, the red line there in the longer 4-year follow-up period is always lower than the green line. The red line indicates the high deductible health plan enrollees, and the green represents the people who are in that more generous health insurance design. So across these types of services for breast cancer, women experienced average delays of approximately 2.7 months, 6.6 months, and 8.7 months to these services. Among high-income women, we found similar findings. So we had been expecting, based on previous research, that a lot of these findings would be concentrated in the more vulnerable population, the low-income women. But we found, in fact, that higher-income women also experienced delays in care, on average 1.9 months, 5.4 months, and 5.7 months to the same 3 services: breast biopsy, early-stage breast cancer, and chemotherapy initiation. So we found that both vulnerable and less vulnerable high-deductible members experienced delays in healthcare. We also found this among women who are in predominantly white neighborhoods, predominantly non-white neighborhoods, women living in metropolitan areas, women in non-metropolitan areas, similar findings. This is a health insurance claims-based study, so the underlying reasons aren't immediately apparent, but one could hypothesize it's certainly related to the fear of the cost or the anticipated high cost of services. And other patterns could be happening. We know that patients often delay care towards the end of the year when they know they're going to hit their deductible. That could be playing a role. And we've talked about comparing health care to food items. So just like a cheeseburger is not always going to be healthy, or hamburgers are not always going to be healthy, health care might not always be healthy as well. There's a lot of concern about overdiagnosis of breast cancer, and that could be playing a role. We just saw from Dr. Colgren that discussions around costs, even though they're not very common, are happening. So, uncertain, but that could be playing a role. We do need to do research about whether these delays are affecting health outcomes, such as time to metastatic breast cancer diagnosis and survival. And some limitation of our studies, that's not a randomized trial, it's observational, so it's always subject to bias, but we tried very hard to reduce those biases. And then what should we do about this? So I think clinicians and clinical teams should consider high deductible health insurance a risk factor, just like other risk factors. And Dr. Colgren laid out some recommendations very eloquently in the talk before, and I would agree with all those. We need help from the health systems, the clinical teams. Patients need to be educated and involved in their decisions, and employers also could implement approaches to improving the knowledge that their enrollees have about their health insurance design. And so finally, we've recommended what we call population-tailored health insurance designs, where health insurance designs are based on evidence of effect in certain populations, and you can do things like value-based designs to reduce cost sharing for certain services to enhance the likelihood that those services will happen. So thank you very much.
All right, I am Betsy Cliff, and I am presenting our work on unintended spillovers after a consumer-focused intervention to increase high-value preventive care. This is a paper with my co-authors Rich Hirth and Mark Fendrick, both at the University of Michigan, and we gratefully acknowledge funding from the Robert Wood Johnson Foundation and the Agency for Healthcare Research and Quality. All right, I had some trepidation about, there we go. So starting with a little bit of background, there are myriad interventions that aim to improve the take-up of evidence-based high-value healthcare. Some of these include health insurance benefit design, including value-based insurance design, consumer engagement, or other quality improvement programs. At the same time, we don't know very much about what affects levels and changes in levels of low-value services. Those are healthcare services that don't improve health. But we do know that medical care often begets more medical care. For example, if these people on the slide go into the medical clinic for an office visit, they may receive a bundle of services that include the office visit and other services. Depending on their age and gender, they could receive specific high-value primary preventive services. Those are those with the green thumbs up. And they also might receive some low-value healthcare services with the red thumbs down. Low-value services here are defined as services that are used a substantial amount of time in people for whom they are unlikely to improve health, and they can differ by demographics and by health status. That's why you see cervical cancer screening in both categories. It's recommended for women between the ages of 21 and 65, but considered low value in many other women outside that age range. So in this project, what we wanted to ask is if quality improvement efforts to increase high-value services might result in unintended increases in low-value services. They might do that by either increasing the number of times you go to the physician, or within a physician visit, the chance that you're delivered a low-value service. So what did we do? We looked for these unintended spillovers by analyzing data from a state employee plan that had successfully promoted high-value healthcare services. We picked it because it was indeed quite successful in increasing the use of high-value services, and we wanted to see if it had unintended effects. This was a plan for employees of a single state that selectively reduced cost sharing and its insurance benefit for high-value services, and in addition to receive those lower premiums and to avoid a deductible, the plan also mandated regular receipt of high-value preventive services. We used claims from this group compared with a control sample of employees from other states, and we measured the likelihood of receiving either one high-value service or one low-value service in the year prior to the intervention and in the 2 years post-intervention. The intervention began in 2011. So this graph shows you our main findings. The bars on the left side of the graph show you the percent of people who received a high-value service in the pre-period before the intervention and then in the first 2 years after the intervention. And the bars on the right show the percent of people who received a low-value service in the pre-period and in the first 2 years of the intervention. The pre-period numbers are the actual baseline percentages, and the first and second year prevalence numbers are predicted from a regression model that controls for baseline differences between treatment and control, time trends, age, gender, and comorbidities. To keep it simple, I'm not showing you the control group bars, but the service use is essentially flat in the control group. So as you can see from these results, the percent of people receiving a high-value service is higher in the first and second years, which is what we had already known from the intervention. But here's the novel part: the percent of people who receive a low-value service is also higher after the intervention than it was in the baseline period. In fact, the relative changes are approximately equal. This represents, I should say these results represent the initial 2 years. After our data were collected, the state has begun to contract with accountable care organizations and implemented other tools that may mitigate these results. So what we found is that an intervention that promoted high-value services unintentionally increased the use of low-value services. This research is consistent with the idea that either patients or providers do not discern service value in primary care interactions. Thus, efforts to increase or decrease services based on value must use precise and explicit incentives for both types of services. This research is not meant as a rebuke of aspirations to increase high-value care. Instead, it calls for better measurement of low-value care and, when appropriate, greater specificity in targeting efforts to reduce that care. The metaphor that we think of is good for this is a set of doors. You don't want to close the door to all services because people will miss needed care, but you don't want to open the door too wide either. Instead, you want to think of benefit design or other quality improvement initiatives as a screen door that encourages the good, here high-value services, and screens out through explicit incentives wasteful medical care. Thank you.
Good morning, I'm Susan Perez. The study, Consumers' Perceptions and Choices Related to 3 Value-Based Insurance Design Approaches, was conducted in collaboration with my colleagues Melissa Gosden, Jessica McPintour, and Patrick Romano, as well as the Center for Healthcare Decisions. This project was funded by the Robert Wood Johnson Foundation. This study explored consumers' perceptions and decision-making in response to 3 different value-based designs. Value-based insurance design encourages the use of high-value services or discourages the use of low-value services by aligning cost with quality. For our participants, we presented 3 value-based insurance designs: narrow networks, These narrow networks are intended to lower premiums, leverage market power, and group networks into different levels based on cost and coverage. Reference pricing. For this example, we presented 3 different hospitals that varied in price for the same non-emergency procedure. 2 hospitals were charged less than the reference price, but one of them more so than the other, which increased the coinsurance. Now, the 3rd hospital was above the reference price. That meant in addition to the coinsurance, participants had to pay the difference between the hospital price and the reference price. Finally, value-based benefit design. This 3rd scenario presented participants with the option of paying less for higher value care or more for low value services. We did this work by first consulting experts and stakeholders who were charged with evaluating and overseeing quality and transparency in the California market, as well as representatives from community organizations that assist with insurance enrollment and insurance agents involved with supporting consumers as they purchase health plans. We use this feedback and information to design our facilitators' guides and a survey. From our focus groups, we learned that when presented with the idea of narrow networks, participants had a difficult time separating their patient-provider relationship with quality of care. That is, they had difficulty accepting that their trusted provider might have a low quality score and could be excluded from that narrow network. Accordingly, participants had difficulty understanding how quality measures are derived. Now, when it came to reference pricing, participants were surprised that hospital prices could vary so much, and they could not disconnect that cost and quality were unrelated, even as we reassured them as facilitators that cost and quality were not related. Lastly, when presented with the value-based benefit design concept, they favored this approach. They felt it put more emphasis on their patient autonomy, and they were minimally concerned with overuse or misuse of treatments. So participants were skeptical and mistrustful of these value-based insurance design approaches, even when issues related to quality and pricing were explained. When disseminating and communicating value-based design options, it is important that we communicate in a manner that emphasizes choice and fosters trust to bring awareness to consumers' options. I leave you with these 3 participant quotes. In response to the narrow network scenario, this participant stated, "His or her ratings are in the back of my mind," like she said. "If the doctor's treating you good, your experience is good. As soon as he makes that mistake, it's over." When discussing reference pricing, this was an example of a participant trying to make sense of the differences in hospital prices. Well, maybe Hospital A is an older facility, tighter quarters, you're sharing a room with a little curtain, but your HIP is still going to be good, just as A and C. It's all kind of in the amenities. And the last quote highlights participants' preference for autonomy by choosing low-value services in response to the value-based benefit design scenario. "I'm the one in pain. Forget what the doctor says. This is intense. Come back in 6 weeks with a pain of 9? What about later on tonight? It's going to be a 15 or a 16. Thank you very much.
Good morning. My name is Madhulika Vulamiri, and I'm a senior Medicaid strategist at the North Carolina Medicaid Agency. I conducted this research when I was in the Masters of Public Policy program at Duke University, and I'm representing a large team here of co-authors that are listed here. So today I'm going to be presenting our work on how Medicaid programs are increasingly offering beneficiary incentive programs to improve health promoting behaviors. So our team performed a landscape review of publicly available information on these Medicaid incentive programs to understand what are the most commonly targeted behaviors as well as incentive vehicles. Additionally, our team interviewed 80 policy stakeholders to identify the rationale behind key program decisions, as well as stakeholders' recommendations for improving beneficiary engagement, as well as evaluating these programs, for which I'll be sharing some potential solutions. So from our landscape review, we identified 113 health behavior incentive programs that were either run by managed care organizations or states across the country, with the majority operated by MCOs, though increasingly several were operated by states through 1115 waivers, state plan amendments, or federal grants, and most notably the Medicaid incentives for the prevention of chronic disease. So as you can see in the top two bars, the most commonly targeted behaviors were pregnancy care visits, so postpartum and prenatal care, as well as wellness primary care visits. And many of these programs targeted more than one behavior. From our interviews, stakeholders suggested that these incentives were commonly built around existing infrastructure. So for example, MCOs commonly incentivized preventive visits that were linked to quality measures. States, on the other hand, tended to target more complex chronic disease-related behaviors, such as smoking cessation or diabetes. In terms of the types of incentives that were used in these Medicaid incentive programs, we found that the most common incentive vehicle was gift cards or vouchers. And this is a category which included cash, gift cards for flexible spending, gift cards for specific stores, vouchers for services like gym memberships, or redeemable points for items like health equipment. And we found that the gift card amounts varied greatly, from as low as $5 to as high as several hundreds of dollars, which reflected different perspectives from our interviewees on what amount of incentive is really needed to motivate behavior change among low-income individuals in the Medicaid program. And then, while less commonly offered, states in more recent years, through their 1115 waivers and other mechanisms, were offering cost-sharing and coverage incentives, as well as social supports and services like offering a peer mentor, and then finally, a few punitive incentives like copays for inappropriate emergency department use. So in our interviews with stakeholders, we often heard that beneficiary engagement in these incentive programs was a key barrier to success, either because of low awareness, low understanding of the incentive program, or low participation. And so our stakeholders identified various challenges, but also offered some potential solutions in this area. So first, consistently reaching Medicaid beneficiaries through traditional channels like mailers or robocalls was a challenge due to Medicaid beneficiaries often being transient. And for this, our stakeholders recommended a theme that we've heard today, which is meeting members where they are, outside of the clinic setting, through local community events or mobile devices and apps. And one state, for example, partnered with local street teams who went to Walmart every Saturday and came up with hip-hop melodies and distributed program brochures to enroll in smoking cessation incentive programs. Next, stakeholders also mentioned that incentive programs can pose additional burden on clinical teams who can be really central to engaging these beneficiaries. So for example, clinicians are often required to sign forms to show that a beneficiary completed a behavior without any kind of additional reimbursement. So key recommendations here included ensuring that providers not only understand the incentive program, but aligning both beneficiary and provider incentives. So for example, incentivizing both the providers and the patients to improve their hemoglobin A1C, or offering electronic referrals to enroll the beneficiary into the incentive program. Next, on the incentive design itself, we heard that while money talks, there can be some limitations. So for example, incentives can be impractical if it's a gift card to a place where a beneficiary doesn't shop, or some of the reduced cost sharing or low dollar, say $5 incentives can be perceived as having trivial value and not worth making the behavior change. So stakeholders recommended that while money could get people into the door to participate in, say, a weight loss program or calling a quit line, it was often the social support that they received or prizes that kept them coming back. And in fact, one of our interviewees described the ideal incentive as a three-legged stool with money for the health behavior, some kind of a health resource like a gym membership, and then transportation as well. And then finally, we heard this theme of beneficiary education and felt that this quote really summed it up, which is that you can't just tell someone to go get a health risk assessment if they have no idea what that is or if they don't understand the value or importance of it, which really spoke to the need for sustained education about incentives as well as the behaviors that they're promoting. And then our stakeholders cited numerous challenges to evaluating incentive programs and again offered some solutions. So we've often heard Medicaid agencies had limited resources for internal incentive program evaluations. Some of these limitations included the cost of evaluations, the personnel with the right skill sets to do it, and specifically we often heard that the technology required to track these incentivized behaviors as well as their health outcomes was one of the most complex and costly aspects of evaluation. To address this, stakeholders recommended leveraging existing infrastructure whenever possible to pair evidence-based programs like a diabetes prevention program that already collects relevant data. Additionally, stakeholders recommended aligning incentive programs to other reforms that might be happening in a state, such as aligning with quality measures that are already being reported. And then stakeholders also recommended the importance of collaborating with external evaluators early on in the incentive design. Another challenge was the insufficiently short time horizon to evaluate and measure impacts on health outcomes. But stakeholders did recommend selecting meaningful process and proximal outcome measures as well as assessing the cost effectiveness of these programs. So in conclusion, as beneficiary incentive programs become increasingly popular in Medicaid, there's a pressing need to generate more robust evidence on the optimal design, implementation, and evaluation of these programs. And important areas of future research include tracking the evolution of these programs and disseminating evidence on their impact on access to care, cost, and health outcomes. Thank you.
Once again, I'm going to ask a quick question of each of you, and then we'll open it up. Frank, the results are quite striking. You went in with an assumption, and I think many people would, that the difference between how higher income folks and lower income folks would respond would be more different than it was. But I wonder if you could give us a little texture here, how you define how different the income categories really are, the cost of the services, just so that we have a sense of how the patient experiences this potential cost, whether they're in the lower income or higher income category.
Sure, thank you. So first of all, we defined income, because this is a health insurance claims data set, we defined income by the neighborhood someone lives in. And so the cutoffs here were if you lived in a neighborhood where at least 20% of people were were below the federal poverty level, then we said you were lower income. So this is really a proxy for income, but it's been validated. It's a rigorous approach to defining someone's income. And we define high income if you live in a neighborhood where fewer than 5% of people were below the federal poverty level. And there was a middle group that I didn't show. And then you saw that the relative increases in out-of-pocket costs, that was a slide with the side-by-side slide with out-of-pocket costs, the relative increases were actually pretty similar. If anything, the high-income group had a slightly higher relative increase in out-of-pocket costs overall. And so, like you said, Alan, we've done previous research where the lower income group almost essentially exclusively experienced the adverse consequences of the high deductible shift. And also surprisingly, we have found, for example, in diabetes, that higher income neighborhood residents did not seem to experience many changes at all in their use of services and when we try to capture adverse outcomes. So that was a bit of the context, and that's why we were really expecting this delay to occur in the lower income group and not the higher income group.
Thank you. Betsy, your screen door metaphor here, I'm thinking, and you go into this a little bit more in the paper, the role of the clinician seems central here. The number of people who go in with a list and say, these are the tests I want or the screening that I want, seems relatively small. It's more, as you suggested, sort of you're in the door, and now the question is what's recommended to you. Can you just go a little deeper into that topic?
Sure, that's a great question. And again, this is a claim study, so we can't get into it as much as we'd like to. You can't really sort of understand what's going on within that clinician visit beyond what's coded out of it. But we did look, as you say, Alan, deeper in the paper at sort of the amount of this increase that we could attribute to the straight increase in preventive care visits as opposed to a difference in what changes inside and outside of the visit. And we found that about 56 to 59% of the low-value service increases were due just to an increase in preventive care visits. So that suggests that the intervention increases these visits, and because of that increase, that's the majority of low-value services are increasing just because of the increase in preventive care visits themselves. I actually expected that number to be higher. I mean, I don't know where that other, the 40-ish, 45% is, whether it's a change in sort of the salience of preventive services or whether it's something else. And I think that's definitely an area that could use more exploration.
Thank you. Susan, your work really highlights a topic that came up in the first panel around what is it that people think of as quality, what kind of information do they use, and how do they process it. So I just wonder, since you wrote the paper without having read the first panel's papers, now that you've heard some of those presentations, whether there's anything you would expand upon this, on the notion of how people perceive quality in the real world relative to how clinicians and researchers talk about it.
Absolutely. So in a world where a lot of what consumers or patients or individuals are seeing in the real world are ratings such as Yelp or Google reviews, these quality ratings come with a bit of skepticism. So one, they think it's just a bunch of other people giving their opinions, and they're just kind of lay audiences about health and healthcare. And on the other end, if it is a validated quality measure, then that comes with a lot of skepticism. It comes with skepticism and mistrust of where that quality measure is derived, as well as is that quality measure taking into account my needs and my values as a patient beyond the clinical outcomes. And so we're at this impasse of these two perceptions of what quality measures mean to individuals on the market.
Thank you. Madhulika, you, in your paper, you talk a lot about the evaluation challenges, but I was sort of thinking upstream. Whenever I go into a meeting, there are lots of people carry assumptions about how people will respond to incentives. What do you know about the evidence base going into some of these initiatives, in addition to just the question of whether we can evaluate them on the back end?
Yes, are you talking about kind of the effectiveness of incentives?
And how much are they throwing darts on a dartboard? Well, let's try an incentive card to get people to stop smoking, or are they really building on an evidence base when they go into those, I guess is my question.
So the general body of research on incentive programs, especially in Medicaid, which is a newer area compared to employer-based incentives, is that the evidence is quite limited and also mixed. Some of the more recent states, especially those that were in the Medicaid incentives for prevention of chronic disease, had much more robust evaluation designs using randomized controlled trials. So that's where some of our best evidence is, and there was some good success, especially around smoking cessation health behaviors. But there is certainly open question about, even if there is an evidence to back up how to design an incentive program, there may be practical limitations to how you do it in the field. So I remember one of our stakeholders was from a state, and they said they actually contracted with a behavioral economist and went through this whole process of designing a really evidence-based, sound program, but when they came to trying to implement it, it wasn't feasible and was too costly. So I think it's having to balance both what's in the evidence and what is feasible.
Great, thank you. A couple of questions, we have time. Let's take you in the center back here.
Hi, I'm Ashley Freeman from the National Patient Advocate Foundation. And I had a question specifically because we always talk about cost of care, but there's a very fine line between discussing cost of care and actually talking about people's personal finances, which is a very intimate subject. So if we're looking for a system that is about health, care, and dignity, we really need to integrate the impact on patients' lives that goes beyond just the impact of that disease. So for example, it has to include consideration for transportation, caregiver needs, loss of work time, childcare, and even things that we might seem as simple, such as groceries, rent, and utilities. So do you all have any solutions or suggestions on how health plans or providers can really create systems that include an emphasis on these costs that usually we forget about, but people find really important?
You're not going to find those in the claims data.
I can start, I guess. I think that's a really great question, and I actually think Alan's comment kind of speaks to it too, because one problem we have right now is that you can't code for that, and so there is no way for, there's no mechanism for health systems in particular, but also payers to sort of to get at these other costs and get at mitigating the other factors that go into adherence and quality and out-of-pocket costs. And I actually think there are some, particularly within Medicaid, there are some promising approaches to doing so, but we're not there yet, is my general feeling.
We engage the expertise of community organizations, the assisters that are contracted through the state of California to help enroll with Covered California. And we found these organizations to be these really trusted resources that were absolutely immersed in the community. And just speaking with these individuals, they were well aware of the challenges of the individuals and their lived experiences in those communities. And for that reason, they were to present and discuss health plans and health options in the context of their lived experience in those other things you were talking about. Although beyond the decision of choosing that health plan and making those decisions, they were left on their own when it came to that. Yeah.
It's a great topic. We had right here in the center also.
Thank you. This question's for Mr. Ware. Shearer Rosenfeld of Parkinson's Foundation. I just was curious if you had done any further analysis on cost impact, if the delaying of services by those individuals resulted in more intensive use of services and therefore greater costs.
Yeah, that's a great question. That's actually our next analysis. And what we're going to do is we're going to look at, it's challenging in claims data to determine whether someone is sicker when they finally reach the system. And given these delays, that's what we're hypothesizing. And we are in a long, laborious process of obtaining mortality data, which will be one way to look at it. But the other is exactly what you said. So our plan is to look at the cost in the 30, 60, and 90 days after someone finally does reach the system or does get diagnosed with early stage or later stage breast cancer. So it's a very insightful point. We have not yet done it.
Take one last question right here.
Thanks, Mike Miller. I'm going to follow up on that and wondered if you did look at or going to look at segmenting the delays in care by stage of diagnosis. I mean, the diagnostic stage of the breast cancer, because there's been a lot of concern, U.S. versus international, that we diagnose a lot of early breast cancer more than other countries.
Right.
Thank you.
Yeah, great question again. We have done an early analysis of time to metastatic breast cancer. I should back up. Claims data is not great for stage of cancer, right? So early stage has been validated, is why we used it. There are a few approaches to looking at metastatic, which have not been as well validated, but are probably not bad. And so we've actually seen delays in time to metastatic breast cancer. But then you say to yourself, okay, so there's a delay in time to metastatic breast cancer. That's probably bad, but it still begs the question of what happens because of that. And so that's also part of our next analysis. We're going to look at time to metastatic, 30, 60, 90-day costs after diagnosis, and then mortality. But absolutely on a great point.
Okay, please join me in thanking our panelists. We have one final set of papers, and it has to do with health plan choice. I'll introduce our speakers as they come up as we move directly into this session. We'll be hearing from Allison Galbraith, Associate Professor in the Department of Population Medicine at Harvard Medical School and Harvard Pilgrim Healthcare Institute. We'll hear from Kate Bundorf, Associate Professor of Health Research and Policy at Stanford University School of Medicine, and Charlene Wong, Adolescent Medicine Pediatrician and Health Services Researcher at Duke University. So I'll turn it over first to Allison.
Great, thanks. I'm really glad to have the opportunity to share our work with you on decision-making experiences for consumers in the individual health insurance market. This is work from our project, the UPIC project, which stands for Understanding Preferences for Insurance Coverage. And this particular paper is work that was led by my colleague Joe Hero, who's unable to be here today. So this work is motivated by the idea that choosing insurance coverage in the individual insurance market is really challenging and very complex and has the potential for significant clinical and financial implications. The ACA marketplaces were designed to help consumers find and choose individual insurance plans through the use of online portals that allow for apples-to-apples comparisons across a number of different attributes with the potential for assistance through decision support and tools and the availability of assistance from navigators and other assisters and brokers, and also the potential for access to subsidies, income-based subsidies as well. So the ACA marketplaces have facilitated enrollment by large numbers of consumers. It should also be noted that a sizable minority of consumers in the individual insurance market continue to get their coverage outside the marketplaces from direct purchase. So we were interested to know how there might be differences in the decision-making and experiences of those who choose plans on the marketplaces and those who choose plans off the marketplaces, in particular for two vulnerable groups. One, those who have chronic conditions or are enrolled with a family member with a chronic condition, and also those who have low health insurance literacy. So to do this, we conducted a mailed survey of subscribers who were enrolling either on or off marketplace in individual market plans from one large regional nonprofit health insurance carrier in New Hampshire and Maine right after open enrollment ended in 2017. And I should note that we're looking at New Hampshire and Maine, so the marketplace that we're talking about is the federal healthcare.gov. So to give you an overview of our findings, first to talk about the sources of help that enrollees use to choose their plan. So first off, we found that those who enrolled off the marketplace were more likely to say that they had help making a decision. And by and large, this source of help was from brokers. So those enrolling off the marketplace were more likely to say that they used brokers than those enrolling on the marketplace. And also of note, is that we found rates of use of navigators to be quite low, 5% or less across the board. And while we found that those off the marketplace were more likely to say that they had help making decision, those who were enrolled on the marketplace said both that they were more likely to say they didn't feel like they needed to have help, but also more likely to say that they wished that they had had help. And those who had low health insurance literacy were more likely to say that they wished that they had had help. So this slide summarizes our findings about experiences choosing a plan, comparing the experiences of those who enrolled on the marketplace in green and those who enrolled off the marketplace in orange. Well, I guess first off, sorry, I want to take that away. I think it's important to note that across the board, on and off the marketplace, it was not uncommon for enrollees to report negative experiences choosing. So more than a third or more of enrollees reported one of several different negative experiences, having difficulty finding the best or most affordable plan, having an experience that was fair or poor, and having to spend more than 2 hours comparing and choosing a plan. But there were differences between those enrolling on and off the marketplace. So first off, those enrolling on the marketplace were less likely to say that they had difficulty finding the best or most affordable plan. And this was also true for the subgroup who had chronic conditions. And also for those who had chronic conditions, enrolling on the marketplace was associated with lower likelihood of having a fair or poor experience and less likelihood of spending more than 2 hours choosing a plan. However, we found that those enrolling on the marketplace were more likely to say they wish that they had had help, which was also true for those who had low health insurance literacy. So I think some of the take-home points from this work, we found that many individual market enrollees have negative experiences choosing a plan, especially those who have low health insurance literacy. But the marketplace enrollees did seem to report better experiences choosing a plan than those enrolling off the marketplace. But they did say they wanted to have more help. So it appears from this work that additional strategies are needed to educate consumers, to simplify choices, and to expand decision support. Our findings are able to inform us that there might be different types of populations who might have different needs in this respect. So we found that the enrollees with chronic conditions seem to have a pretty good experience on the marketplaces, and this might be because the marketplaces provide them with provider finder tools or drug finder tools, and so this may help enrollees who have known defined healthcare needs. So this might be a population to target off the marketplace to develop these resources. On the other hand, for enrollees with low health insurance literacy, choice experiences were pretty bad across the board. And so this is suggesting that perhaps tools need to be even more simplified, or conversely, maybe this is a group of people who need more direct assistance, not just with tools, but through navigators or through brokers. And it might be important for us to try to boost up those resources, which will be a challenge given that funding has been cut for the navigators. But I think then, in terms of overall conclusions, the marketplaces have facilitated coverage for many, and for many, they do seem to improve experiences. But now I think that going forward, we need to go the next step to try to improve decision-making experiences for people on and off the marketplace so they can choose the plan that best suits their needs. Thanks.
There you go. Okay, thank you for the opportunity to present this brief snapshot of our project. I encourage that folks who are interested to read the article as well as the reports that we did for PCORI. Has lots of what I think is interesting detail. I'd also like to thank my fantastic collaborators on this project. You folks have already heard from Ming Tai-Seale, who is a co-principal investigator on this project, and you heard from her this morning. And of course, we are grateful to PCORI for funding our research and for giving us the opportunity to work with our great patient and provider stakeholders. Okay, this project was really motivated by the fact that we have lots of evidence in the research literature that it is difficult for people to choose a health insurance plan, but much less evidence on how to help people make choices. And when I say that, I mean we have little evidence on specific interventions that seem to work in solving the problems that people seem to face. So in this project, we were really after, we want to develop a tool, a patient-centered tool, to help folks choose among health insurance plans, and then also evaluate it. So through our PCORI-funded research, we conducted a series of mixed method, focus group, and qualitative research studies to understand what were the barriers for people making a choice, how did they make these decisions, and more specifically, how did they interact with electronic tools that were available on the market. And from that research, we developed kind of 3 core things that we wanted to incorporate in our tool. The first was automatic importation of prescription drug information. So beneficiaries told us that that was very difficult for them. For most tools, they have to type in all their prescription drugs. That was hard. We watched them do it, and we could confirm that it was difficult. So we worked with the Palo Alto Medical Foundation in partnership in order to use data that they had on folks from their electronic medical record and make it easily available and accessible in the tool that we built. We also focused a lot on user-centric design, and there were a lot of little moving pieces in here, but it was really important to engage with our stakeholders to understand what user-centric design meant for them. If I had to summarize it in 3 quick words, I would say simplification, larger font, and printing. Right. So those were, kind of the, 3 things that stuck out. But of course, there were lots of other little things about buttons and et cetera. The final thing that we wanted to incorporate was the availability of expert recommendations. When people talked about choosing a plan, lots of people said, well, what I would really like is someone to help me. I would really like an expert opinion on which plan I should choose. We think when they told us that, they were thinking about a human being. But what we did in the tool is we decided to incorporate electronic or machine-based expert recommendations. We kind of incorporated an algorithm. And the algorithm we incorporated was basically an expert score. And the score was a kind of a weighted average of the individual's total cost to them for prescription drugs in each of the plans available to them, and a measure of average plan quality, right? So it's the average of out-of-pocket spending, including premiums, and plan quality. We, when people saw the expert recommendation, we gave them the score, and we visually directed them to the 3 highest score plans. So in the evaluation project, we compared the effectiveness of 2 versions of the tool, one with and one without the expert recommendations relative to directing people to publicly available resources. So in our study, we basically looked at 4 primary outcomes. The first was plan switching, and you can see the results for plan switching up there on the left side of the slide. In the arm with the expert recommendations, people had higher rates of switching than in the control arm, where rates of switching were about 28%. See, I need larger font myself. I can't even see those numbers up on my on my own slide. So I'm empathizing here. So in the expert recommendation arm, rates of switching were about 8% higher. Switching in itself is not enough. Although we have evidence that many people could switch to a different plan and get better coverage, it's possible that our intervention would move people in potentially the wrong direction or further from the plan that would be best for them. So we also had other outcomes. One was satisfaction with the choice process. We saw that was highest in the arm with the expert recommendations, and we also calculated expected savings on prescription drugs and saw that those were greatest in the arm in which folks had access to expert recommendations. We looked at level of decision conflict. We thought that was maybe a mechanism by which we would see people, a mechanism explaining the effects that we observed, but we didn't find any evidence that that decision conflict varied across the arms. Interestingly, we did find that people with access to either version of our tool spent more time choosing a plan. And a priori, we didn't have an expectation of whether more or less was better in terms of the time they spent choosing a plan. But when you combine more time with lower expected savings and higher satisfaction with the choice process and a greater likelihood to switch, we think it's at least consistent with people being more engaged in the choice process. Some important contextual information for our study is that we experienced a lot of selection into our experiment. We basically invited just over 29,000 people to participate in our study, and at the end of the day, we had 1,185 people enrolling. Not all of those 29,000 people were eligible. We couldn't determine eligibility precisely when we invited folks, but no matter how you look at it, there was a significant selection into the trial. Equally important, there were differences between those who enrolled and those who didn't enroll in our study. Those who enrolled in the trial were younger, they were more likely to be male, they were healthier, they were more frequent users of the organization's electronic medical record, less likely to be racial minorities than those who were not enrolling. So in conclusion, we think, overall, we think that this was a success and that the set of older adults that used our plan, used our tool, were kind of better off and had a better experience choosing their insurance products. So we think that many older adults could benefit from patient-centered online decision support tools in this context. We also think that the machine-based expert recommendations were effective, at least in this context, when we incorporated them into a patient-centered decision support tool. And finally, we take very seriously the issues of selection into our study. And while we think individualized information is very important and expert recommendations are probably important too, we need to think about different ways of designing tools or disseminating this information or engaging people that are effective for people who are potentially less engaged in decision-making in this context, but for whom this type of personalized information would likely be valuable. Thank you, and I look forward to your questions.
Hi, okay, I'm the last one standing between us and lunch. So thanks so much for the opportunity to present our work. All right. I am presenting on behalf of my group of co-authors from Consumers Checkbook, the Duke Margolis Center for Health Policy, and the Leonard Davis Institute of Health Economics, all of which help support this particular project. I think the former two speakers have made the case that choosing health insurance is really hard. The landscape is becoming increasingly complex. And so what we sought to do in this study is to examine the role of assisters and automated decision support tools, some of which you've already heard about, in consumers' marketplace choices. And we went to those human beings who are experts in thinking about how consumers choose plans. We went to assisters. We elicited the perspectives of a national sample of experienced assisters, 32 of them from 10 different states, some of whom used healthcare.gov, and others who worked in state-based marketplaces from the icons you can see on the screen here. In our context, assisters were referring to navigators as well as certified application counselors who provide in-person and/or phone-based support to help consumers narrow their plan options on the Affordable Care Act's health insurance marketplaces. Similar to some of the findings presented earlier, assisters identified many challenges that consumers face in selecting a health insurance plan, but they also provided examples of strategies they use to help address these challenges. In response to what assisters perceive to be confusion over weighing the many different costs and benefits that are laid out in front of consumers, and also too often a very narrow focus on the premium cost, assisters elicited relevant needs and preferences from the consumers, with one assister saying, we try to walk through their cost in the previous year, then the situation they're in now for the next year, including worst case scenario and the financial consequences. Assisters also all spoke about consumers who chose to remain uninsured because it was just too costly or they weren't willing to pay the price. And so these assisters help these consumers who chose to remain uninsured by educating them about lower cost local health care options, really focusing on how consumers could still access health and health care. So one assister said, our local hospital, which was not doing any discounting for uninsured patients, is now writing off anything for anyone with an income of up to 300% of the federal poverty level. And this is information that they would share with consumers who weren't able to purchase a plan at the time of working with an assister. And finally, assisters universally, I think, has also commented on very limited health insurance literacy for many of the consumers they served. And they also provided examples of some metaphors that they would use to help explain some of these key health insurance concepts, particularly for consumers for whom English and our health insurance system is completely foreign. So for example, one assister said, I explain provider network to them as la red, which is Spanish for cable network. They get that because they understand and use their cable network. Assisters made several observations on the challenges of using the decision support tools available on the marketplaces and explained their strategies for mitigating these tool shortcomings. For assisters who encountered an out-of-pocket cost estimator like this one shown on the screen here from healthcare.gov, several assisters noted that there was confusion over what the estimate represented, both to consumers and quite frankly to some of the assisters we interviewed as well, who, particularly for those who weren't in states where they had an out-of-pocket cost estimator available. One assister said, I think a lot of my clients think this is all I'm going to pay for the year. They see it as a maximum out-of-pocket number. And then assisters were also telling us these same consumers would be coming back into their offices later in the year saying, what's going on? I am paying way over that number that you showed me when we were looking at plan options. And so assisters employed, again, various strategies to combat this issue with consumer understanding. Several of them actually said they focused more on the out-of-pocket maximum by estimating costs in a good or a bad year. This one sister said, I do a what if. I provide costs from number 1 based on a good year to number 2 based on a bad year. This is what you're looking at, so people better understand the range of what they might be on the hook for. Assisters also made observations about provider network and drug formulary lookup tools, such as this provider search tool shown here. While assisters said that in general these tools were a good starting point to help consumers, they cited inaccurate data, including out-of-date network and formulary lists, which made these tools less helpful, perhaps also small font and the pain of having to input all of your individual medications as well. They also said that there was lacking information in these tools, most notably tier-level information for both provider networks and drug formulators across many of the marketplaces, as well as for providers. They said a lot of their consumers wanted to know what languages those providers spoke. The assisters in our study went to great lengths. We were really surprised with the great lengths they went to verify coverage for consumers that they were helping. One assister said, I call the doctor's office. I ask for somebody in insurance or billing rather than the first person who answers, because they had learned through experience, often that first person who answers does not know the answer to the question that they need answered for the consumer sitting next to them. They also really went to great lengths to help consumers search for alternatives. We had assisters telling us they were calling pharmacies while their consumer was sitting there, asking the pharmacist, are there any substitutes of a similar medication that this consumer could take on this plan, and what would that cost be? They would also look on different drug coupon websites like goodrx.com to see if there were alternatives there. Two priorities emerged for optimizing consumers' marketplace insurance selection process. The first is to improve the quality of data used in decision support tools, and the second is to invest in assister programs, as was alluded to earlier. For the quality of data, improving that quality of data should include developing additional mechanisms to calculate and explain out-of-pocket spending estimates that incorporate some of the assister strategies for explaining, for example, costs in a good year versus a bad year. Tier information also needs to be added in provider and drug lookup tools. As people in this room, I'm sure know, seeing a tier 1 versus a tier 3 provider can have substantial financial consequences. But as Allison and Kate alluded to earlier, I think even with improved tools, assisters said they worked with many consumers for whom no matter how good those automated decision support tools are, they're still not going to have a good chance at making an informed choice around health plans. And so for those particular consumers in particular, we would need to have more investment in assister programs. Assisters in our study really demonstrated how they both elicit and synthesize consumers' needs, emphasizing both plan design as well as healthcare access, including helping people use that insurance once they already have that plan. Despite the services that assisters provide, we've seen these very dramatic reductions in funding for Navigator programs, up to 80% in 2018. And finally, assister approaches should be considered the benchmark upon which to base improving marketplace decision tools, and their expertise can be leveraged in developing the next generation of tools to simplify the complexity of choosing and using health insurance. Thank you.
Great, a couple of questions, and then we'll wrap up on time. Allison, you mentioned that the data come from a location that was using healthcare.gov. There are some states that have built in some decision support elements and some simplification items like standardizing plan options and the like. I realize your data are your data, you can't go, but I wonder if, and apply them elsewhere, but I wonder if based on your work, you have any hypotheses about some of the techniques used in other exchanges that might be responsive to the concerns that were raised.
Well, yeah, I think especially for the enrollees with low health insurance literacy, I think to have a more simplified choice set to be able to choose from would go a long way for, so people aren't feeling overwhelmed by that choice. And that could mean either a smaller number of plans or to have more standardization of those plans, which I think some of the state-based marketplaces are doing more than healthcare.gov.
Thank you. Kate, it's striking to hear the interest in experts when we just had a panel where people talk about how they don't trust the experts. I wonder if part of this is it's different to think about an insurance company or the price of a drug versus the quality of an interaction with a clinician or a hospital. But I just wonder if you saw that the same way I did, or if you have any observations or thoughts about what seems to be a different statement coming out of the people that are the basis of your study.
Yeah, so that's a great point. I hadn't really thought about the contrast between experts in providing care and experts in that context and experts in the context of insurance choice. I think that people were curious about who the expert was behind our expert recommendation, and they did ask questions, and we can see them clicking on the button to see, learn more about who this expert was, who this expert is. We also told them actually what was actually in the expert score. So maybe in this context, it's a little bit less ambiguous, right? What actually is in the score. I think this is a really important issue, though, in thinking about machine-based expert recommendations and algorithms to help people with decision support more generally, because as the algorithms become more and more sophisticated, it will be they could be more helpful, but they could also be biased in certain ways and, at a minimum, less transparent in terms of what's going on. So I think those trade-offs are really important things to watch going forward.
And that leads, Charlene, to the question about establishing trust between the assisters that you talk to and the people who are trying to make decisions. They are a form of expert, but they're also a form of narrative, and credibility there seems central. I wonder if the assisters, from their point of view, had any observations about the basis of the trust relationship with their clients.
Yeah, the assisters had a lot to say about that, especially when we were starting to ask them about the decision support tools. They were like, yeah, the decision support tools can do some of these things, but it can't ever replace what we're doing, because we start by talking to the consumer or the person sitting in front of them about their family. It is a true partnership, I think, as we heard about on some of the earlier panels, that is formed between the assister and the person they're working with. One of our co-authors is, actually two of them, are certified application counselors, and so as we were developing our script and really thinking about what we wanted to talk with the assisters about, we had that perspective as well going into it. So
that's great. Can throw a question here. Wait for the microphone, please.
Hey, thank you all so much. Amit Rao with Baker Donaldson. So my question is, what is kind of the next tier or set of features that automated decision support tools need to work towards? At first with the exchanges, we were like, great, we're comparing plans all from different carriers on one website. It's just like Kayak. And then we're like, wait, maybe premiums alone aren't ideal. Then we looked to Tier 2, which came on in 2015, 2016, out-of-pocket cost calculator, provider lookup tools, drug formulary lookup tools. As your research is showing, there are some limitations to what those tools can do as well. Have we sort of reached the limit there? Are we hitting diminishing returns? Or is there like a third tier of features or needs that they could address on the next iteration?
That's a great question.
I'll take a stab at that. I maybe because I'm from Silicon Valley, but we have not reached the limit here, right? So I think, but seriously, I think that there are, when I look at the tools that are available, they seem like, they're like baby steps into what people need and what we can potentially do with technology. I think one thing that is a challenge here is, especially in the context of health insurance, is getting people's data into the tool. And that is, as we learned from our experience in doing that is very complicated due to regulation and privacy and things like that. So I think we're going to have to balance those things and trying to think about how we can get people's data into tools more easily. And then, I feel like there's tons of low-hanging fruit. Get in the provider networks, right? That would be awesome. Doing the one thing that folks talked about in our context was, it came up in the slides here, thinking about risk, right? So the way the navigator did it is, well, here's kind of a worst case, and here's a best case scenario. Coming up with ways to use data to communicate that information to people, I think, think would have a lot of value as well. So I think there are tons of things to be done here in many ways that we can make these better. I want to say one more fast thing. I also think that the tools are not a substitute for navigators. They are a complement to navigators. So if the navigators had better tools, they would be better navigators, and maybe they would be able to serve more people.
And I can add to that, not really from this project, but other papers that we've published, some in Health Affairs, looking at the tools that have been available and how those have really evolved, as you said, over the last several open enrollment periods. When we looked at some of the exchanges that are run by private entities, not healthcare.gov or the state-based exchanges, we did see some of this more nuance. Some of them had little cute flags that had, low cost, large network, best value. Again, sort of where the transparency and how you came up with those flags, is still questionable, but they also had, tools where there were multiple steps so that the consumer could walk through multiple steps of filtering and narrowing down their plan so that they could help see a narrow set, but also sometimes we're already starting with a narrower set on some of these other exchanges. So I agree, I think there's much to be done.
Yeah, I think that more information could be put all together into an algorithm that responds to patient preferences. So, your tool had a lot of great data input, but you could imagine it as you're choosing to ask, how important to you is your provider being in the network? Okay, that narrows it down. Okay, and then is premium important? Yes. How risk averse are you? Narrow that down. Where do you live, or just other, to make it much more patient-centered to give a set of recommendations in that way. I just also want to hit back on the point that the accuracy matters a lot. So I don't know that we necessarily need a whole lot of new types of tools, but they do need to be more accurate. And patients need to be able to trust them to tell, once you have one, these are consumers who go back every year and choose again, and they need to know that last year when it said your provider was in the network, and then they weren't, that they can go back to that tool and it can be helpful to them.
Okay, as we wrap up today, in addition to thanking PCORI for their support and the New York State Health Foundation, and in a moment I'll ask you to thank our authors here, I'll just close by noting the tension between so many efforts at nuance, whether it comes to plan design, guiding people to low-price, high-value services and the like, and then the desire for simplicity so that people can actually make decisions, and somehow mediating between the complexity of the system and the simplicity that makes decisions possible. That seems to me to be a recurring theme today. So thank you for joining us, and please join me in thanking our final panelists as well.